I'm Jim Friedman. I'm the Executive Director of the American Academy of HIV Medicine. I want to welcome you all. I'm pleased to see you here today. I do want to note that we are videotaping this session, and it will be available on our website starting early next week, I hope. This forum is directed at the HIV practitioner who's on the front lines of delivering HIV care. Over the last couple of years, several significant policy changes and initiatives, most importantly, the Affordable Care Act, have set in motion a lot of changes that will impact your practices. And we think it's important that those policy changes are translated into things that are meaningful for the practitioner, so he or she can get involved in the activities at the state and local level and adapt his or her practice to facilitate all of that. And today we have gathered together a stellar group of senior federal officials and policy experts who will help translate those policy issues into information that you can use in your practices. They will provide some insights and some clarity in what is to come into your practices in the next couple of years. It is my honor to introduce the moderator for today's session, Mr. Richard Sorian. Most recently, Mr. Sorian served as the Assistant Secretary for Public Affairs in the Department of Health and Human Services, helping President Obama and Secretary Sebelius in communicating to the American public about health care. While Mr. Sorian has held a number of very important policy and communications positions in and out of government over his career, the ones that are held most important to me, and I think to a number of others perhaps in this audience who are doing health policy in Washington, D.C. in the 80s and 90s. He was the editor of Health Legislation and Regulation from 1980 to 85 and from 1985 to 93, Medicine and Health. These were newsletters, came out weekly, that told us in government, and I suspect others in health policy, what was really going on in health. And he was the guy that was the editor for all of that. So we're really pleased to have him here as the moderator. Again, it is my privilege to introduce Mr. Richard Sorian. Thank you.
Thanks, Jim, and thank you for including me today. You know, early in your career, you pad out your resume so that it doesn't look like you just started last week, and I'm now at that stage in my career where I have to start cutting things back. So I actually worked when there was only paper and nothing was online, and every once a week was enough time for people to know what was happening in Washington. So you can see how much things have changed. But one of the things that I was proudest of was some of the earliest reporting on the epidemic before it even had a name, and when it had some really bad names early on. And that work does continue, and I want to welcome you here, but also welcome you back to the International AIDS Conference in the United States. It's been a very, very long time since we've had the ability and the honor to have this conference in our country and in our city, so I hope you are enjoying the time here. We actually managed to get the temperature down for a day or two, but don't depend on that. It'll go back up very soon. We have a very exciting afternoon planned with a lot of really key experts on healthcare policy, and in particular on HIV/AIDS and the delivery of care to patients. So I just thought it would be useful to set the context a little bit before we dive into the specific issues. You can imagine, as we were preparing for this conference a few weeks ago, there were some rather big unanswered questions. The fate of the Patient Protection and Affordable Care Act was hanging really, in some ways, we didn't realize how thin a thread it was hanging by until the final decision by the Supreme Court. But we were trying to think, well, if the Affordable Care Act is overturned before the conference begins, we're going to have to do a lot of work to try to rework the whole agenda. But for many, many reasons, that one the least of which, I personally was extraordinarily pleased and really just almost ecstatic that the law was upheld. But there is so much work to be done and so much more that we need to understand before we can actually implement an historic law like that. Let me talk a little bit about some of the major provisions, just so that it provides, as I said, some context for the conversations to come. The Affordable Care Act attempts to tackle some of our bigger problems in healthcare, and it does so first and probably the most important of which is to try to dramatically reduce the number of uninsured people in the United States. I have had the honor occasionally to either meet with international delegations from developing countries, from fully developed countries, and all the kinds of countries in between. And I have to tell you that whenever I explain that in my country about 15 to 20% of our population has no health insurance. I remember looking at a group of Turkish government accountants who had come to study the U.S. healthcare system, and they looked at me, and through their translator they said, "Did you really say that there are 50 million uninsured people in your country?" And I said, "Yes." They said, "Well, in Turkey we all have health insurance." And I said, "Well, in almost all other countries we do." Well, the Affordable Care Act won't make every American eligible for insurance, but about 2/3 of the 50 million people who are currently uninsured, or about 30 to 35 million people, will gain access to health insurance that they don't have access to today. Second, it invests heavily in public health and prevention, two issues that are dear to all of us in this room and to the people that we work with and the patients that you serve. Rather historic investments in both public health and in prevention, really putting prevention higher on the agenda of healthcare. It's always been sort of the stepchild in many cases, particularly as the government looks at it. And then third, trying to bring down the rate of inflation in healthcare, but doing it in a more rational way. There have been attempts, and very unsuccessful attempts in my view, to really just take a hatchet to healthcare spending by the government. Various times they all sit down and they say, we're going to just take this much off the top of the healthcare system and then leave it to the rest of the system, the doctors, the nurses, the patients, the hospitals, et cetera, to figure out how to work with less money, but not really address some of the underlying reasons that were driving healthcare costs up and up. The way that they are going about it is really to work with hospitals, doctors, and patients to start changing the delivery systems of healthcare so that they have more prevention in the front end, they have less redundancy, and hopefully better systems of delivering care. But all of that is yet to come. And that's where I think all of us are most concerned about how this plays out over the next few years. So a couple of things in terms of, as you know, this law was passed in 2010, but its major provisions are still being implemented, and most of them don't go into effect until 2014. But even today, beginning in 2010, after the President signed the law, there are programs in every state available to people with pre-existing conditions, including HIV/AIDS, who have been unable to buy private insurance, to sign up for a program called the Pre-Existing Condition Insurance Program. And in Washington, we have to have an acronym for everything, so these are known as the PSIP programs. They are in every state. Some of them are run by the federal government, some by the states, but every state has them. And people are eligible if they have a pre-existing condition and if they have been unable to buy health insurance. So they have to have at least attempted to buy private health insurance. That PSIP program has about 50,000 people enrolled in it across the country. Some states have larger numbers, but it hasn't been an extraordinarily popular program, not because of the structure, the fact that it would cover people with pre-existing conditions, but because the costs are fairly high. The PSIP premiums are aimed at the market average, so they can't be charged a lot more than somebody who's healthy, but the market average in our current system is often too high for most people to pay the whole premium themselves. So In some cases, tremendously helpful program, particularly people who have very high health care costs, because for them, even a high premium is well within what they need to spend on, much less than what they would spend if they didn't have it. So 50,000 people. And when it comes to HIV/AIDS, that has been a very important program. The Medicare program, which covers people who are over the age of 65, but also people with disabilities, including people with HIV/AIDS in many cases, has also been changed so that the prescription drug benefit, which was passed in 2003 and has a significant hole in the middle that they call the donut hole, that has begun to shrink so that people are getting lower costs for the drugs they buy while they're in the donut hole. And in particular, it's important to note that in the ADAP program, the costs count towards the Medicare out-of-pocket limit. So people with high costs through ADAP actually get lower costs through the Medicare program already. Children with pre-existing conditions can't be denied private health insurance. Insurers are very limited in their use of annual limits on benefits, which often cut off coverage right at the time somebody gets sick or very sick. And the federal government has begun to invest in both in prevention, but also in the federally qualified health centers, also many places known as community health centers, so that they're both supporting the ones that exist, but beginning to give states and communities money to build more facilities to help people who either have no insurance or have limited ability to pay for care. In 2014, we'll see these fairly major provisions kick in, and I'll just quickly tick them off here. Private insurers throughout the country will no longer be able to deny coverage to somebody based on their medical condition. So if somebody has anything from asthma to cancer to HIV/AIDS, insurers would have to accept them as a customer and could not charge them more than a healthy customer. That's a tremendous change in the health insurance market, as you can imagine. The annual limits that I mentioned earlier will be gone, but so will lifetime limits. So people won't be able to buy a policy that suddenly cuts off when their illness is at its most expensive and most critical stage. Insurance companies won't be able to charge women higher premiums than men. They won't be able to charge small insurance companies higher premiums than small companies and their employees more than they charge large companies and their employees. And then people with income between 133% of poverty, which right now is about $18,000 a year, and 400% of poverty, will be eligible to buy health insurance in what are called state insurance exchanges. And they will receive fairly significant tax credits to offset much of the cost of that insurance. And then finally, for people with incomes below 133% of poverty, below that $18,000 line, the Medicaid program is going to be expanded to provide coverage in states for people, including single adults, as well as families with children. We're going to talk a lot more about that, as you can imagine, in the coming discussion. Finally, the one provision of the Medicaid law, and I think our next speaker will probably be touching on this in more detail, so I won't go into detail, but you heard the Supreme Court upheld the Affordable Care Act, but one thing they said was that the Medicaid expansion, which was pretty much mandatory for states to adopt it, has now been more of an optional expansion that states can or cannot decide to adopt. So we have a lot more debate and a lot more fighting, frankly, to go in the years to come. All of this creates, in my opinion, a great deal of hope for people living with HIV and AIDS, a great deal of support for their families, for their caregivers, for their physicians, and for their communities. But like any big change, it creates a lot of uncertainty. And that's why I think today's discussions, where not only will we hear from the experts, but each of you will have the opportunity to ask questions and get answers to things that you're thinking about as you look at your practice, as you look at your patients, and you look into the future. We have some of the leading experts on HIV/AIDS policy, both from the private sector and the public sector, so I know we're going to have a very informative discussion. To start that off, let me introduce our first speaker, Dr. Stephen Cha, who is the Chief Medical Officer for the Center for Medicaid and CHIP Services at the U.S. Centers for Medicare and Medicaid Services. So that agency oversees the federal Medicare program as well as the state-run Medicaid program and the CHIP program, Children's Health Insurance Program. They provide coverage for more than 60 million, almost 1 in 5 Americans are in these programs. And Dr. Cha, in addition to the work he does with that area of the budget, also promotes health transformation and modernization for Medicaid and CHIP, which are going through changes and will continue to in the future. Before joining CMS, Dr. Cha was a senior professional staff member for the Committee on Energy and Commerce in the House of Representatives, working for Chairman Henry Waxman, who is one of the leaders and, frankly, in my opinion, one of the heroes of the AIDS epidemic response by the federal government. And he worked for him as they shaped the Healthcare Reform Act that was passed in 2010. So without further ado, Steve.
Introduction. So yeah, my name is Steve Cha. I'm the Chief Medical Officer for the Center on Medicaid and CHIP Services. It's just a fantastic opportunity to be able to be here and speaking with all of you. I think this is a critical time to take a moment and think about how we're approaching some of these 2014 challenges and what we can do now, because now is the time to think about it, not in 2014 and 2015. So I especially appreciate the forward-looking nature of your leaders to invite us to speak to you and begin this conversation now rather than later. I'm also a practicing primary care doc. I see patients every Tuesday evening. That's been part of what I've been doing since I got to DC, working on the Hill, even through health reform, and I think it's provided important insights for me in terms of how we think about health policy, but in addition, I still consider myself a primary care clinician by heart, and that's who I am. The other thing to mention is that this position is a new position at the Center of Medicaid and CHIP Services, and I think that's relevant from this perspective of a new direction that I think we're trying to accelerate our progress towards thinking how we at the Center on Medicaid and CHIP Services can be better and more forward-leaning partners, how we can better match up and promote what we know is good evidence-based policies out there. That, at the end of the day, when I think about my job, I work on delivery system reform, I look at quality, I work on a lot of discrete issues, but the question that I sort of think about every day and I go home thinking about every night is, are our policies and procedures supporting the best evidence-based practices that are out there? And if not, what can we do better? Or if there's obstacles, how can we reduce those obstacles? That's my challenge, and tremendously been gratified to see that our leadership, both Cindy and at the department and all the way up, have been tremendously supportive of this idea and this mission of trying to think about that job at CM, at the Center of Medicaid and CHIP. In particular, transition for people with AIDS and HIV to full insurance coverage is a critical topic. And I think there's a lot of things to unpack here in terms of thinking about what this means as we move forward. I wanted to focus maybe in the talk in three ways. First, talk a little bit about what happened in California, and some of you know a little bit about what happened there, some of our lessons from that, and then want to have some time to engage with you all about how we move forward from those lessons. So starting with California, I think many of you may have heard about what happened there. There was, I think someone forwarded me an article in your magazine, The HIV Specialist, by Ann Donnelly and Courtney Mulhern Pearson, I think, who are here. I thought it was a fabulous summary of what the challenges are and how we need to be thinking about this. But just to give you the quick snapshot, in November 2010, California took the feds up on our option under ACA to begin expansion early, essentially, and expanded to significant numbers of new people. And there's no question that this was a good, positive thing that we wanted to figure out how we could best support. There's no question that expanding coverage is a helpful thing. I think because Ryan White can only be the payer of last resort, we realized sometime down that road that people were going to be facing some abrupt transitions of care, and I think there were a lot of concerns, rightly raised, quite frankly, in terms of how that transition was going to unfold. CMS has been working with the state, the county, with our HRSA partners, and with public hospitals to revise that plan in a way that, frankly, we didn't quite collaborate on before that plan was written. And we certainly had collaborations with all those agencies, but really unpacking this specific question to really think about how this works, to create an amendment to their 1115 amendment. And I should back up. 1115 amendments are waivers that we offer to states to allow them to restructure their Medicaid program, so long as it's serving the purposes of the program and it's budget neutral. And so California took us up on our opportunity and the opportunity to expand to significant new numbers of beneficiaries. So we worked with them after on this amendment, and the amendment will ensure that people with HIV make as smooth a transition as possible from their Ryan White providers to what we're calling these low-income health plans, which are really county-based plans, and that transition happens without a loss of core medical or other critical services. And part of the way that we're doing that is it creates a new category of incentive payments for providers for HIV activities to address the issues of access, continuity of care, and comprehensiveness of services, medical home being the most obvious piece of how some of those incentive payments are going to flow, trying to work with HRSA to ensure that the same standards that now apply to Ryan White providers also apply in the context of this program. So this is where some of these lessons that we realized after the fact, and we're trying to adjust that plan as we go forward. So what are some lessons? And I'm curious for the policy panel, since a lot of those people have looked quite closely at this plan as well, to hear some of their reflections as well. But from our perspective, I guess two pieces to start out with in terms of lessons learned. One, regarding the transition to full coverage, there's no question in my mind as a physician who cares for patients that having coverage, all other things being equal, is better than not having coverage. There's just no question about that. Our patients are better served when they don't have to face all the challenges that we know that we've, and I know many of you have struggled with. And that's a good thing. And then putting on my hat in terms of my Hill days, I remember the yearly travails of trying to think about Ryan White funding and the issues about ADAP every year and thinking and worrying about that. It was a constant concern from us at the policy level as well in terms of how we'd address that. So from the first perspective, as much as Ryan White has been a tremendous success, there's no question that having coverage is better than not having coverage. The second point to acknowledge, in particular in the context here, is that there's also no question that Ryan White has been an invaluable support and provides some incredible ranges of services that standard insurers are not picking up as well, and includes incredible components, incredible strengths to that program that we need to think about. So this is, in my mind, an opportunity. It's a real opportunity to pull down and draw and create that base of coverage provided by Medicaid, and then think about how Ryan White can interface with there, and learn the lessons about what Ryan White has done well, learn the lessons about what coverage has provided well, to think about moving forward to create a more cohesive and comprehensive system for our patients than ever before. This is the real opportunity. But this opportunity is not going to happen, and I think this is one of the real lessons, without some significant work and collaboration. So how do we move forward? And I would identify 3 specific areas to think about within the sort of moving forward category. The first is collaborations at a national level. Second is collaborations at a local level. And the third is how we think about delivery reform. So collaborations at a national level. We need to do a better job within HHS, within the administration, about how we can coordinate and ensure that we are presenting a unified front in terms of how we're moving forward. I'm getting involved in some of these now. As I said, I'm new to the agency, but jumping right in, and I think it's a real opportunity from my perspective to think about how we can unpack some of these. The Presidential Advisory Council on HIV and AIDS, some of you may be familiar with. This is a council specifically convened to try and address some of these issues. I've just started joining in on those meetings and plan to engage more fully as time goes on. But we need to think about at a very high level how we're thinking about this. The second piece is to unpack that even further, some of the staff level context between HRSA and CMS. When we think about how we can specifically unpack some of the details, it may not happen in these blue ribbon panels. It may be just getting the work done and being more effective in that fashion. And from that standpoint, I can point to the work that we engaged on with this HIV amendment in terms of working with our HRSA colleagues at a very low, I shouldn't say medium to the analyst level staff, working together hand in hand to think about how do you unpack these problems. That's what it's really going to take to unpack some of these solutions at the national level. So you need collaborations at the national level, both at the high level in terms of how we're thinking about this from the leadership perspective, but also how we're thinking about this when we actually unfold the policies from the national level. That's not enough, though, and I think that's only going to be a small piece of the picture. The real key is going to be collaborations at the local level. I can't emphasize that enough, and this is not a punt. This is not a way of saying we're not going to be engaged as well. We will be. I'm telling you right now, we're going to be working to try and collaborate and coordinate as best we can, but this cannot happen without that local level work to ensure that the current providers and whatever system is transitioning in are all at the table thinking about how this new system is going to look. The state Medicaid agencies, the state AIDS agencies all have to be there together, advocates and providers, and to think about a transition plan that reflects the needs and strengths and problems and issues of that particular state and area. And I think under that, I think needing to ensure that whether it's the MCOs or in this case the low-income health plans or whatever that system may be that's developing in that particular state to expand coverage, to ensure that that's capturing the providers that need to be served there included, and to be ensuring that everything from the benefit package to the formulary is addressing the needs of people with HIV and AIDS. That's all going to happen primarily at the state and local level. So we will continue to be engaged, continue to try and do our best to coordinate from the national level, but it's incumbent upon folks like yourselves to really get involved with this process to ensure that this reflects the needs of your patients and the people who need these services the most. So that's collaborations at the national level and the local level. The third piece, and I think this folds across both of these, what can we do to better support some of the lessons about delivery system reforms that we know can be helpful to our patients? And that's everything from within Medicaid under the ACA, we have a new provision called the health homes. This is a provision that provides enhanced services, an enhanced package of services, care coordination, and those types of services for people under Medicaid program with a 90% match for 2 years. And so we, the feds, are going to pick up most of the cost for that, for these health homes for a significant amount of time, recognizing that at the outset in the early years, a lot of this is infrastructure costs. It's hard to absorb those costs at the local level. We're saying we're going to invest our federal dollars and pay for those for 90% of those costs for 2 years, and then transitioning into, once that infrastructure is built up, to the regular match rate. I think there's a real opportunity to think about designing health homes to address people with HIV and AIDS in terms of how they can best fit those needs. The second piece is, again, part of this whole agenda that we have at the Center on Medicaid in terms of trying to, what we're talking about is Medicaid moving forward, this idea that we're trying to accelerate our pathways towards change, accelerate our orientedness towards evidence-based practices. We released 2 letters 2 weeks ago, and I think we're calling integrated care models. And these were letters to state Medicaid directors saying that you have new flexibilities under your authorities that you may not have been aware about to design what we're calling integrated care models, delivery system reforms, whether it's ACOs, shared savings, medical homes, whatever you want to call it, systems that are designed more towards patient-centered, accountable care. And we're expressing new flexibilities that the state has to do these without a cumbersome administrative process. We're really excited about this, and we're excited to work with states to think about how to implement some of these integrated care models. But regardless of whether it's the Health Home Authority under the ACA or the integrated care models that we just released last week, I think the bottom line from Medicaid is that it's a complex program, certainly, but we have a number of authorities. Medicaid, unlike other programs out there, has an extraordinary amount of flexibility to work with, so long as states and providers and stakeholders want to go in a certain direction. More often than not, then we can find some way, and we are trying to be more creative than ever about how pathways to ensure that we get there, as long as we're focusing on the needs of the patient. I think our focus and what we talk about is something that many of you heard about in terms of the 3-part aim. That is, things that we know, and we know there's a set of interventions out there that we know can improve the experience of care, can improve the health of populations, and reduce the cost of care. That's where the sweet spot is, and there's a tremendous set of opportunities, particularly in a population like people with HIV and AIDS, to think about how we can do our jobs better, and what it would take for Medicaid to get that job better. We're here to listen to the ideas that are coming to us from the states and think about how we can better support the best evidence-based practices out there. The third piece, of course, is that interface with Ryan White's programs. We know that some of the Ryan White providers have been doing this with the Ryan White support for years already. So to the degree we can avoid reinventing the wheel, obviously that's better. And so to the degree that we can either think about how that support will move going forward or think about keeping those same systems and thinking about new ways to financially support those, all of that is engaged in a conversation primarily predicated not at the national level. Again, what's happening at the state and local level, how that Medicaid program is designed, how that state AIDS program is designed, and what's happening at that state level, and how we can best from the federal level do our job to support what you're all doing out in the field. So I guess the question that I hope I would hear more from you, and the reason that I would want to listen, is how can we be more supportive? What can we be doing? What should we be thinking about? Again, I think this is the right time to be having this question. California went first, and I think provided some important object lessons for us. It was incredibly useful for the rest of the country, frankly, to see what happened there and to learn from that experience about this opportunity we have. And I really think it's an incredible opportunity that we have, and how we can walk down that opportunity and maximize the potential for improving the systems of care out there. I have no doubt in my mind that come 2014, when the Medicaid expansion hits, that this is just a tremendous way to improve care for the populations that we serve. There's no doubt in my mind about it, but we have to do this right. We have to think about drawing the best from the new opportunities and pulling the best from the worlds that exist now, and how can we blend that together. I know that's possible. I also know that work like that is hard sometimes, and what I'm telling you, that from our perspective, we're ready to roll up our sleeves to work with you, and we're hoping that you're ready to work in your local communities to do the same. But I wish I could tell you that this is going to be a cakewalk, but I don't think it will be. But I do think that there's tremendous amount of benefits for providers and patients at the end of the road. This is a situation where we can't pass up this opportunity. There's just such an amazing chance to improve the lives of the people we serve, and I hope to work with many of you to make that happen. Thanks for your time.
So Dr. Cha has some time for a few questions. If folks can go to the microphone and start off just by identifying yourself so that we know who you are, and ask whatever questions you'd like. Thank you. Yes, ma'am.
Hello, thank you. Dr. Debbie Holmes, Miami AIDS Healthcare Foundation. Big question is, how can we achieve these challenges when your governor doesn't even want to expand the program? Already in 9 states, the governors have decided that they don't want to expand the program, and I know that the feds are supposedly picking up, I think it's 90% of the cost for the first 3 years. I mean, and here we are in Miami, which now has the highest rate for any city of HIV in the country per 100,000, and it's just, yeah, you put pressure on the Congress people and work with your politicians, but I think there should be some type of mandate to cover these people and get the word across. If you get people into care, maybe we could get control of the epidemic.
I mean, I couldn't agree with you more. I think that the Secretary wrote to the governors on July 10th, and that letter is available, I'm sure, online. If you just Google HHS and July 10th governors. And I think she summed up what we're trying to say the best, which is it's time to move forward. There are multiple ways that we're working with states in their efforts to try and expand. We are covering 100% of the costs of this expansion population from 2014 to 2016, 90% of the costs thereafter. we're frankly very hopeful that all states will eventually take advantage of this opportunity. But a lot of governors are saying things now. I don't think any of this is sort of written in stone yet, and I encourage you to continue those conversations in your own localities. I think we're doing what we can from the federal level in the context of the Supreme Court decision to send as strong signals as we can. Is we're ready and willing and hoping that all of you want to work with us on this, because we think this is a fantastic opportunity for patients, but frankly also a fantastic opportunity for state budget coffers as well, which is, I know, ultimately what a lot of folks are facing. When you think about the uncompensated care coming through hospitals, and the fact that states are paying for many of these folks one way or another, I mean, you all know these arguments, and we stand ready and willing to work, but there is no mandate that we can issue from on high about that. All we can say is continue to express our willingness to work with everyone in terms of how this can unfold. One added piece on that front, which is that I did work on the Hill for 6 years, and particularly when I left, it was, I would say, a relatively unpleasant conversation at times. And I think one of the most refreshing pieces about coming over to CMS, despite my fears about some of this and some of the frontline and headlines about Medicaid, ULC, I can tell you that in every state, including your own, there are fantastic people working to make good things happen at every level, and every red state or blue, and at the directive governor or within the context of broad outlines. There's great stuff happening all over the country, and so I think that obviously the Medicaid expansion is better, but I think that there's still opportunities no matter what happens moving forward. But I feel confident that governors will see this eventually, and I think providers will probably help in that conversation at that state level to ensure that everyone sees what a good deal this is. So I remain confident, but we'll see. We get dealt the cards we have.
Dr. Shah, I'm Ian Gilson from Medical College of Wisconsin in Milwaukee. And first of all, I don't know whether to offer congratulations or my sympathies with taking on one of the most challenging jobs in the history of American medicine, but best of luck.
Thank you.
But as we all know, probably the biggest challenge in HIV care is adherence. The biggest issue in adherence is mental health. And the biggest issue in mental health, in my mind, is how can we deliver it in an effective, evidence-based way in primary care. And the evidence is accumulating that the way to do it is with teams including integrated mental health professionals with primary care doctors and nurses. And frankly, we can't do this right now in most Medicaid systems. There are models. The VA, for instance, is one model where it seems to be done. And I wonder if you are developing a Medicaid medical home, are you thinking about a strong mental health component with built-in funds so that mental health people will actually take these jobs and do the work? Because I think we'll get better outcomes and it'll ultimately be cost effective if the adherence rates goes up as they do when you treat depression. But how do you envision the integration of mental health? Right now in Wisconsin, at least, I don't see it happening.
So this is a great question. I should also say my Tuesday evening clinic is in a substance abuse transitional shelter for homeless guys who have been in a substance abuse program, and this is their transitional housing before they launch, and so there for 6 months to a year at a time. I see this every Tuesday night in terms of and I should say I practice in a non-integrated system where I try to call the psychiatrist to figure out clozapine issues, things like that. That's obviously the most basic, but everything in terms of the patient will tell me something that I know the psychiatrist needs to know, some new element of suicidal activity or something like that, and I would say less than half the time I make that connection, even though it's just hard, and I don't blame any of the providers on the outside. It's hard, but it's also not good care. So what are we doing from the federal level? I would say there are a lot of things happening, which is good. So when I talk about these delivery system reforms, when I talk about the various ways we can support them, I would say the majority, I don't know about the majority, but I would say a good chunk, if not the majority, pretty close to the majority, of the health home proposals we've gotten so far have been behavioral health and orientation. It's recognizing, and again, part part of the state's interest here is that these are also their cost driver populations, right? And so there's a great argument to be made to the states to say, these guys are costing you a lot, and we're not doing a great job of taking care of them. So this is, again, when I talk about triple aim, great opportunity to unpack this. So a lot of those are oriented towards the health homes. That 90% match I was talking about is oriented towards behavioral health population. The second piece is that within a lot of these waivers, these restructuring of funds that I'm talking about, I'm thinking about Oregon right now. A key piece of their restructuring in terms of their delivery system reform was, in fact, reorienting and integrating the primary care and behavioral health, actually physically in their model, putting them in the same place. And we couldn't be more supportive of those sorts of ideas. The challenge here. So I would say from our perspective, again, I think numbers of authorities, whether it's health home, whether it's a waiver, whether it's, again, these ICM kinds of things I was talking to you about, a number of ways that we'd be delighted to support these efforts. What I've heard about in the challenges is that behavioral health and substance abuse is talk about silos. You have Department of Health, you have sometimes Department of Medicaid in a different place, and sometimes you have departments of mental health services in yet a third place, and these three groups not talking and thinking about the opportunities to align here. So I think that's a challenge, and I think it's incumbent upon, again, folks like yourself saying, here's a great opportunity, here's a great model of care, and trying to think about importing that or importing an element of that to your state and thinking about pitching it to the right folks. It's hard work, though. The third thing I'll mention, recognizing that, is something that just went live last week, which is the state innovations models. This is a grant from the Centers for Medicare and Medicaid Innovation. We've been working with them for months to unroll this, and we're very pleased this is getting out there. This is specifically a grant opportunity for governors to think about large-scale reforms that they want to execute from the governor's level. So I think this is a great opportunity to think about when you think about crossing silos. It's an opportunity for a governor to say, okay, well, my three silos here, I'm going to use this money that CMS is offering to maybe think about, let's get all the people in the same playpen and get going on some of this sort of stuff. I think substance abuse and mental health. I think about maternal child health. I think about things that are divided, and HIV, I think about things that are often divided across silos at the state level. This is a great opportunity where we're putting money on the table for a governor to say, we want to help you get there. So we have 5 states, 5 awards that are available for 5 states for relatively large-scale projects, and then about, I think, 20 grants available for small, more sort of design, planning and design grants possible for some of those states. So I would say from our perspective, we're trying to do whatever we can to really push and move forward on that. We're eager to work with states and try to unpack that. As I said, I think we have a number of authorities to support those kinds of models, but we got to hear that from, Medicaid is ultimately a joint state federal program, and unless the state comes to us and says, we want to do X, again, going back to the last question, there's very little that we can mandate down, or that we want to, because it would never get executed well. We want to work with states, and especially here where there's such a great argument to be made for triple aim here. So appreciate the question.
Thank you.
Dr. Chow, Dennis Myers, nurse practitioner, certified with the American Academy and board certified in family practice, and I practice in Kentucky and Indiana and have a significant HIV and family practice number of clients. I'd like to address the Ryan White leg of your discussion. If the Ryan White CARE Act continues to adhere to the payer of last resort clause, what good is it today? I recently quit a Part B and C Ryan White clinic because it became increasingly difficult and untenable for us to get comprehensive primary care services through the Ryan White funded clinic. We went backwards. Instead of a one-stop shop type clinic which we developed through the Ryan White CARE Act and CARE practices, we now had to fraction our care and concentrate strictly on providing HIV services only, when given the fact that HIV is now a chronic disease, we now need more primary care integrated services. So how can we expedite transitioning HIV primary care into primary care services today? I think that's what is sorely needed.
And I think that's exactly the right question. that we should all be grappling with. And I think that's precisely the question that I'm saying we all need to engage with, both at the federal level and at the state and local level. I think the short answer is that it's going to depend. It's going to depend on the state. It's going to depend on the locality. It's going to depend on what the services that are being offered and what the state has been offering before. That's the dodge. The more direct answer is that I think there are absolutely opportunities to think about how we redesign that one-stop shopping center. That's what we want, right? We want systems to be able to support comprehensive, integrated, patient-centered care. That's what we all want. Whether it's the Ryan White program or the Medicaid program, that's our goal. And I think that through Medicaid, forming a foundation and a basis of that fundamental, broad-range, comprehensive, and affordable benefits, which, frankly, folks never had before under Ryan White in some respects, and we all know that in terms of the gaps there. Forming that finally as the basis for our patients, and then thinking about, well, Ryan White has been doing a great job at some of this other stuff, even if it wasn't always a comprehensive package of benefits. It was doing a great job on some of these other services and other wraparound service and other things like that. How can we integrate these systems? And so in California, as I said, I think what we did was try to think about stepping back and saying, how can we build those and bake those into this proposal? And I think most of those, frankly, still came through the Medicaid money and funding stream because of the way that particular state was structured. And that's why I'm saying it's going to depend on every state. But that trying to incorporate the systems of care, trying to incorporate the lessons of Ryan White, working with our HRSA providers to say, here's what we do well, here's what the best systems are doing, and bake that into the proposal. So the specific solution is going to vary, but it's just so clear to me that this is an opportunity to actually move forward rather than seeing this as, but I will say there's a danger, certainly, and as we saw in California, if we don't stay on top of this, to have that more further fractionate and have that package of service dissolve, and I think that's the concern. I think that's right, and we need to continue to follow that.
One other note, I work in an area where infectious disease doctors don't want to take care of HIV anymore because of the primary care issues, and primary care providers do not want to take care of HIV because of the complexity of it. Fortunately, I've been trained in both, and I've been able to integrate, since leaving the Ryan White Care Act, into my primary care practice 100% of my HIV clientele. But that's not feasible for all providers. So yeah. Hopefully maybe through the American Academy we can train more providers and people that can branch out and help these people. I don't know, but that's the dilemma I'm having in the area that I'm in. Well,
as a payer, I don't think it'd be appropriate for us to say what that model of care should be. I think that's up to the professionals, but I do think that we should be holding folks accountable for the kinds of quality outcomes both in primary care and HIV medicine, and how that unfolds for the system. In this idea of designing these systems is going to be up to the system to how to execute. I'm getting the time signal. Should we do rapid fire and then I can maybe take all these three at once?
We can just the folks that are standing, and we'll have opportunities as we go to the next panel, but instead of adding to the line, if we could just, I'm sorry, sir.
Should I take all four? I mean, how tight for time are we?
Oh, we're okay for about 5 more minutes.
Okay.
So
go ahead.
Okay. I'm Anita Case. I work at an HIV clinic in South Carolina where we have a governor who's not going to expand Medicaid. My question is, we're very heavily funded by Ryan White program, and we have a medical home model of care for our HIV patients. What I would like to advocate for, or find out if there's an option for, is the enhanced Medicaid reimbursement rates that community health centers get through the 330 funding for Ryan White funded clinics that already have a medical home infrastructure in place after 20 years of funding, as a way of moving those clinics forward, especially if Ryan White funding is going to diminish with the Affordable Care Act, especially for states like mine.
So this is, and I would probably take a shot at this if it weren't for the fact that Dr. Hobson's going to be here later. I think that's specifically under their rules in terms of who gets to be and who doesn't get to be under the 330 funding lines. But as I understand, an FQHC is very clearly defined by statute. And they don't have a whole lot of wiggle room from even HRSA's ability. So it's about that statutory definition, including the community-based board. And you've all heard this before. But there are pathways to become an FQHC. But again, I think that's beyond my scope of knowledge to some degree. And once they tell us they're an FQHC, that's when we sort of say what the payment rate is, but with the PPS issues.
No chance for the Ryan White funded clinics.
As I said, I don't think that there's, I think that's entirely up to Well, number one, if you statutorily change things, obviously that's a different picture. But I think barring changes in statute, and I wouldn't count these days on so much change in statute.
Maybe I should clarify. We do see Medicaid patients, so we get paid by Medicaid for
I
the
understand.
non.
I understand. But in terms of the question is, can a Ryan White provider become an FQHC, essentially? And I think that's going to be basically a Ryan White provider can be a federally qualified health center, sorry, which is the HRSA definition for who gets the 330 grant money. And unless there's something that Dr. Hobson knows that I don't, it seems to me the answer is the way to become an FQHC is the same way everyone else becomes an FQHC. So there's no going to be, I don't think there's a specific pathway for a Ryan White provider besides just simply qualifying under the standard laws and regulations.
And we will have a senior person from HRSA later today, so save that question and ask it again when she's here. Sir.
Hi, Dr. Cha. My name is David Munar. I'm President, CEO of AIDS Foundation of Chicago. Thank you for acknowledging the problems with the waiver, the 1115 waiver in California, and something that we've been monitoring closely. And there's an opportunity for CMS to make sure that future waivers are implemented in a better way. Cook County in Illinois is applying for a waiver, and we need to make sure that as the state negotiates with CMS, that we carefully look at the network, adequacy of the network, that we look at integration with Ryan White, that we avoid the pitfalls of California. And it's the county-based waiver, so there, it could fall under the same trap if we're not really careful. And we're also looking very closely in Illinois around the health home option. And I'm glad you mentioned that. And I think it's really important to look at, and I'm glad you acknowledged the Ryan White systems. Ryan White, though it's limited by an administrative cap and low appropriations and challenges, in many examples, we're getting very close to the kind of integrated model that the health home aspires to. So I think there's a lot of opportunities there. And I would just offer two quick recommendations. One is there could be, or there ought to be, through the CMS Innovations Grant, an opportunity for Ryan White networks to apply for innovations money, and that would bring the HRSA world and local providers closer to their state counterparts on Medicaid. And there's the HIV Health Access Working Group, which is a big coalition of advocates, is requesting that CMS identify an official, high-level official, to work on ACA implementation, specifically around the needs of people with HIV. Another recommendation I would ask you to look at. So my question is, you talked a lot about Ryan White and HRSA, Ryan White and ACA coming together. Can you describe, I know your time is brief and I've taken up a lot of it, just specifically what CMS is doing to work more deliberately, intentionally with HRSA on Ryan White integration with the ACA?
As I said, I think I outlined a couple, both at the high level, sort of the Presidential Advisory Council on HIV and AIDS level, high-level discussions, which both myself and HRSA are at the table for that. Also reaching out on the individual waivers when they come down and make sure we're tapping in the expertise in terms of the program analysts in terms of their best knowledge about what's going, because a lot of this is in the details. It can't be just platitudes about, yes, let's coordinate. It's got to be how we actually unpack this problem, work together. I frankly think the second is harder. We get a lot less buzz and a lot less sexy recognition for it. But I'm telling you that's going on now, and that's what I'm most pleased about, trying to see how this moves forward. I'm not saying we're going to get this right every time either. I think that's why I'm saying most important is not what we're doing at a national level, but what you all are doing at the local level, because no matter what happens, we will always ask, what are the comments from the local level? What are your stakeholders saying? And if those comments are in there, we will get those, and we will see those and be able to understand, oh, well, here's a problem that they've identified with the particulars of their system. You got to be involved in that level of that conversation. So even if we're not directly engaging in this type of forum, that's how you get involved. That's how we can figure out how to work this all together. And frankly, a lot of these states want to do this right as well, and that's how they can learn about how they do this well. And I think California was an experience where I think everyone had the best intentions, and I think it was a situation where, as it unfolded, we realized situations and things we should have done that we're trying to now apply moving forward. So I have no magic bullet. I'm not going to sit here and say, here's the magic formula. What I can tell you is that we're trying to get together both at the high levels, the medium levels, and every level to try and think about how this works. But we need you all. We need you guys to be at the local levels weighing in with those waivers going forward or those proposals going forward so that when we ask, or even so that they know what they should be doing better, so that we can all make sure this works out for the folks that you serve.
Something like the Innovations Grant would help bring some of those local providers to the table.
I think the SIM is something to take a look at, the State Innovations Model. It's a lot of money, and I think it's a potential real opportunity in terms of aligning the forces here across the various levers we have.
Actually, he really asked the same question that I was going to ask. I mean, fundamentally, I work in a community health center in Tucson, Arizona, do Ryan White care. We're funded through Ryan White. And one of my fantasies is, well, what happens when 2014 comes along and all of my patients move to Medicaid or some other form of insurance? And truthfully, we have a very comprehensive system. I have a psychiatrist on site. I have behavioral health counselors on site, adherence counseling, all these things. I think I have a fabulous program. And I'm just not sure, and I can't in my dreams figure out how we're going to maintain that in the future where we're under Medicaid or insurance funding alone. And so I guess my question and my hope is, and as you said, I really hope you guys, CMS, are working really hard with the folks at HRSA-HAB to figure out how we're going to continue to do this. And again, that's really, someone already asked my question, so
yeah.
Short.
And I think it's going to be incumbent upon all of us to try and make sure we get this right every time. And I think that's a great opportunity for me to just close with a few comments. But you know, I think that when I think about 2014 and when I think about the expansion, when I think about the potential for patients to have actual coverage, an actual insurance card, as much as Ryan White has been just such an incredibly invaluable program and has done so well in certain areas, this is nothing less than a major, huge step forward. And I think everyone in the room knows that. I think we've all hit, as much as we love Ryan White, we've all hit those bars. And I think that that's fair to say that it's constrained by the fact that it's a discretionary program with certain parameters. Transition to Medicaid takes those problems away, a lot of those problems away. So we are in a new world where we can build upon that. But, and so that's a real step forward in terms of offering patients comprehensive, affordable benefits. The second challenge for us is to ensure that we capture the best of what Ryan White is doing now. And whether that's funded by Medicaid under one of these authorities that I mentioned, medical home, integrated care model, state innovations model, whatever, whether it's one of those or whether it's some way to integrate Ryan White and the Medicaid funding together, I think we still have to unpack that box in terms of how that moves forward. But this seems like much more of an opportunity than it is something that is a negative. But the only dangers are that we need to work together and coordinate better. And that's never easy. And so, again, I think all I can do is offer our word that we're going to try and do our best to work hard at this. But we need you all there as well. So I appreciate the opportunity to talk with you all. Please spread the word about what's going on here. And if there are other forums, other ideas you have for us to continue to think about this, broader stakeholder calls, whatever, I think this is a message that needs to get out there, and we're committed to try and engaging that conversation and listening to what we need to be thinking about differently from all these experiences. So I want to thank you for your time here, and thank you for the opportunity to address you all. And I'll be able to stay for a little bit while longer, so I'm interested for the next panel and some of their thoughts as well. Thank you.
Thank you, Steve, and thank you for setting the table really for some really in-depth conversations to come, and especially to the 6 people who asked questions. You've really helped us make sure that we're addressing the points and the concerns and the questions that you have. So we're going to have a panel discussion here, and we're going to do it a little differently than the usual Washington approach in that nobody's brought slides, nobody's making opening remarks and presentations. The whole hour is going to be an interactive conversation between the experts but also with you. So I'll ask a few questions to get things going, but at some point we're going to open up the mic again for folks to ask questions and to add topics to the conversation so that we make sure that nobody leaves here today without at least hearing some conversation about a topic that is of important interest to them. And then we'll really try to be as flexible as possible. Let me do brief introductions, and I'm going to do it the way it's written on the paper because I can't do it in the order they're in because I'm just that inflexible guy. But so the great thing is there are new and old friends here at the table, and not only for me, but these are people who often work together so they can really work off each other on some of these important issues. So Jen Cates is the Vice President and Director of Global Health and HIV Policy at the Kaiser Family Foundation. And if many of you who've worked in this field know, the Kaiser Family Foundation has been dedicated to addressing this epidemic since it began and is a major force in the public reaction and response to this epidemic. Jen oversees the Foundation's policy analysis and research focused on the U.S. government's role in the global health and on the global and domestic HIV epidemic. She's a published author and often presents on these topics at conferences here and abroad. Dr. Donna Sweet is, many of you know, the current chair of the Academy and a practicing certified HIV specialist caring for patients with HIV for more than 25 years. And let me just thank you for that. As somebody who's had friends and family get HIV care from caring doctors, we don't take a lot of opportunities to thank you and for all that kind of work. She and her team currently care for approximately 1,200 patients living with HIV in Wichita and 3 outreach clinics in rural Kansas. She's past co-chair of the CDC HRSA AIDS Advisory Council and currently the national vice chair of the Health HIV Board, where she's leading an effort to address the U.S. HIV medical workforce shortage issues. Courtney Mulhern Pearson joins us from the San Francisco AIDS Foundation. So picking up on the conversation that Dr. Cha started about the California waiver, and not just that issue, but we've got an expert from on the ground in California. She's Director of State and Local Affairs for the AIDS Foundation in San Francisco. She's responsible for developing the Foundation's state legislative and budget agenda and advocates for full funding of HIV care and prevention programs in California. And again, the San Francisco AIDS Foundation, one of the earliest NGOs that just arose from the community to fight for and fight back for this epidemic. So we're glad to have you here. Amy Killalay is a senior manager with NASTAD, the National Alliance of State and Territorial AIDS Directors, working with their health care access program. She's helping to lead their health care reform implementation efforts. And NASTAD has, as you can tell by the name of the organization, they have representatives from every state in the country who have been working both at the state level but here with the federal government to really make sure that the federal response is sensitive to the state needs and really hearing directly from the people that are on the ground rather than here in Washington trying to work at the national level. So a very important collaborative. Jeff Crowley is recently the President Obama's Director of National AIDS Policy and a Senior Advisor on Disability Policy for the President, an internationally recognized expert who has been working on this epidemic from both the government level and the private sector level and academia for many years, despite his youthful appearance, I swear. He's been working on this for a long time. He had a real critical role in the development of the Affordable Care Act as it affected not just people with HIV/AIDS, but all people with disabilities, to make sure that the act, when it was finalized and as it's being implemented, really addresses the very special needs of those populations. And did I get everybody? Okay, there we go. So let's just start off trying to build on the conversation that we just had. Let's start with the sticky issue of Medicaid. So now the Supreme Court has made the Medicaid expansion optional for states. One, what can organizations and individuals like the people here in this room do to advocate for their state to adopt this expansion? And then perhaps even more importantly, how do you see that expansion playing out, particularly vis-a-vis the Ryan White program that has been so important both to people with HIV/AIDS but also their caregivers? I'm going to just start with Courtney and move things down this way, but after this first go around, just feel free to raise your hands and I'll try to pop around.
Is this on? Okay.
Great.
So thank you so much for having me. I'm pleased to be here and bring some of the lessons we've learned from California to all of you, and I hope you can learn from our experiences and maybe not repeat everything we did. So the question in terms of, I feel like I'm not entirely qualified to speak to states that are not planning to do the expansion, because I'm obviously in a state that is moving ahead very aggressively with expanding Medicaid. You can handle you can handle that part. But from a very outsider, maybe naive perspective, it seems like we need to reach beyond sort of our normal advocacy alliances, and I think working with, well, not that they're not normal partners, but really looking to the hospital groups, pharmaceutical companies, insurance companies, other sort of allies that really will share our goal of expanding Medicaid to this population. From an outside perspective, seems like a start. And then in terms of 4 states that are choosing to expand, I think, and specifically for people with HIV and our providers, we expect, at least in California, I think this is true nationally, that about 70% of our Ryan White clients in California will be moving into Medicaid or are already moved into Medicaid. So obviously as providers, that's going to be a big change for us. So really making sure that you are connected to the Medicaid program in your area. In California, we've also moved forward again very aggressively with mandatory managed care. So currently all seniors and persons with disabilities must be in managed care. So starting that process now, we found that the contracting process is quite difficult, and that there's not enough technical assistance available often. So again, using opportunities like this to talk to each other, AAHIVM probably can be helpful in sort of helping facilitate some of that as well. But again, I think Dr. Cha said it well, the work really needs to start now. And making sure that we're ready for this population when they fully transition.
Thank you. Well, there couldn't be more contrast between states, between California and Kansas. So Donna, if you could talk a little bit about what's happening in your state, but also how you think those kinds of coalitions might work in other states as well.
Certainly. I sort of empathize with a number of the speakers that were at the mic. Being in Kansas, the governor has not only stated that he has no interest in exchanges. I was part of a Medicaid advisory group that applied for some of the early money to be able to plan exchanges. Kansas was one of the lucky states that got $31.5 million. And the minute my governor took office, he sent it back, saying that we don't need federal help and we're not going to do exchanges. So that sort of sets the stage for where we are. He's also not about to even address the Medicaid expansion issue until after the November elections. He still considers it a repealable, revocable law, that he intends to stay with that premise until the very end. So we'll see what the voters do. But the real issue I think we're going to have, even if we could get Medicaid expansion, in Kansas there is a dearth of physicians who will take Medicaid at all because of the sort of the hoops you have to go through as well as the low pay for what you do. If indeed we suddenly covered the 141,000 people in Kansas who would be just general patients, not HIV, but 141,000 people who would supposedly have access and have a Medicaid card, does not mean they have care, because there are nowhere near enough providers to take care of that population. I think the other real challenge for those of us, I have, as the young woman from South Carolina said, I think I've built a very good program, thank goodness, because of HAB and HRSA and their programs. We have put together a comprehensive medical home for well over 1,200 HIV-infected individuals that I can give them comprehensive care. There is no way that is maintainable with any sort of the current pay mechanisms that are out there for Medicaid and private insurance, because the infrastructure would go away. One of the things that Dr. Cha said was that we have to try and figure out how to, build that infrastructure. The problem is you can build it if you don't sustain it with the appropriate amount of resources. You can't continue to do it. And I think therein lies the real frustration of those of us who have built, as Kevin has out there, and Jim, and all the people that have big long-term HIV functional clinics, to see that come apart because of new funding streams is going to be very difficult for those of us who have watched it for so long. So again, I think the chief problem, even if we expand Medicaid, is going to get providers in it. Even those who want to be a part of it are going to have to learn to jump through these hoops in terms of how to fill out the forms and how to end up being on the right managed care contract. And quite frankly, there may be some bias on the part of many of the managed care companies not to include the people who they very much should have in there that are HIV experts for various reasons. So I think there are so many challenges ahead. And again, we were all waiting for the Supreme Court decision. 90% of it was what I'd hoped for. I don't think any of us really, I certainly never foresaw this part of it with not making Medicaid expansion something that had to be done. I think it being an opt-out phenomenon is going to be very difficult. But we're still going to have problems with the rules about if there is any sort of Ryan White funding, funding of last resort, and all of the things that have been brought up. So challenges, and we still have to continue waiting because I don't think many of us, the governors that are leaning one way or the other, aren't going to say anything until after the November elections.
Jeff, you've been on both sides of advocacy and being advocated too. What's the best way to make this argument, whether you're in a state that's totally resistant or one that says they're going to wait and see? What are the best arguments in this issue?
Well, I'd say a couple things. I mean, first, I'd like to build on what Steve and others have said. You know, insurance matters. And so we can be concerned about what's going to happen, but people will be better off when they have a right to a defined benefit package under Medicaid. So I think it's something we want to happen. As Donna said, I think we really need to just wait to have this conversation to some extent after the election. But I do think that, you know, she convinced me over lunch that her governor probably won't take up the expansion. But I don't think really other states can say confidently what's going to happen. One, it's not up just to a governor. It's a governor and a legislature. But there's so many incentives why they may really, at the end of the day, expand Medicaid. Just the high level of financing available, but also the other things in the ACA, including the cuts in dish payments that fund uncompensated care. So there'll be a lot of pressure. But I think that, you know, for us to make it happen, we just need to be making the unequivocal case about why it's a good thing at the state level, you know, for so many people. The other thing I would just say is, you know, just to hear Steve talked a little bit about what happened in California, and I think, you know, I'd say a couple things. One is that sometimes I hear anxiety within the HIV community about what we're going to lose with Ryan White, as though Ryan White's the only place that people with HIV get good care, and that's just not the case. You know, Medicaid is the largest payer for HIV healthcare services in this country. A lot of people get good care, and I think it's possible. So I don't think we need to overstate our anxiety about this. But there's no doubt, and certainly when I could speak for the administration, what we always said is, even after the Affordable Care Act's implemented, we're still going to need a Ryan White program. So part of what we need to do is make the case for why we need to expand Medicaid, but then adapt Ryan White so that they work in complementary ways.
Jen.
Well, it's hard to follow off all these folks, and I'm sorry Amy has to go last because it's going to be even harder for her. But just to add a couple thoughts, and sorry I missed the earlier conversation, but the way I think about the Supreme Court decision is to say, you know, in general, the Supreme Court upheld almost the entire ACA. And I think that's really important to remember, including the new mandatory eligibility group, which is low-income people up to 133% of federal poverty. That is still a mandatory group now under Medicaid. Obviously, by saying that the Secretary of Health and Human Services didn't have the constitutional authority to penalize states by taking away their Medicaid funding if they don't expand, is why we are all saying it's in effect become optional, but that group is there. And that's been the first time in Medicaid's history that that has been the case. And I think we have to remember that. As Jeff said, you know, we don't know what states are going to do. There's probably a subset that we can kind of be pretty sure about, but I think it's really going to depend. And there's many different things you can look at. You know, there's 25 states, plus Florida brought the initial suit the day the ACA was passed. 25 states joined it. 13 states wrote amicus briefs in support of the ACA. 2 are in both camps because their attorney generals and their governors disagreed. So, I mean, I think it just shows you that this is a very complex terrain, and with the match being essentially, you know, it won't cost states much to do this, and they're already paying for that care in different ways. So I think we really have to wait and see. But regardless, even if the ACA had been fully upheld, I believe that Ryan White would always be playing an important gap-filling role, not just for undocumented individuals, but for people who fall through the cracks in this country, which would happen. Now, with this new decision, I think it's going to be, you know, it's even clearer that Ryan White will continue to play a role be the safety net under the safety net, both for current, for states that maintain their current Medicaid eligibility rules, for states that maybe expand, for exchanges, for basically the healthcare system. It will play a different role, but it will still be pretty important.
Thank you. Amy, I'll turn to you, and then I'll also promise that I'm going to go the other way around the next time around. So.
I really appreciate that.
You're welcome.
Yeah, I don't have too much to add to what the other panelists have already said. I will say that I agree with Jen in terms of thinking about the decision. It was an incredibly narrow decision, and the Medicaid expansion was upheld. What was not upheld was the enforcement mechanism. So a state still has to actively not comply with a mandatory expansion. And I think that's important from a legal perspective and just sort of a messaging and framing perspective going forward. And that being said, regardless of that sort of legal truth, I think we're still going to hear a lot from governors and from state health officials who are going to get out right away, right now, and say, no, we're not going to expand. And that's a fear. And I think, the response in the states, and this is going to be a state battle, I think, not just on the Medicaid expansion, but a lot of these implementation decisions, I think, are going to be kicked to the states. But I think, some of the things that were raised are just going to be very important. This is a really good deal for states. This is 100% federal funding for 2014 through 2016, and then down to 90% following. That's huge, and that's an incredible amount of federal money to leave on the table. And while I think that's going to be difficult for governors to do, and then when you couple that with the fact that it was a very narrow decision, every other Medicaid reform stands, including the reduction of DSH payments. And that's you're going to have hospital associations and a whole lot of people who have a vested interest in making sure the Medicaid expansion goes forward and stays on your side. And the only other thing just to throw out there, so Arkansas, that's another state that, not incredibly supportive of the ACA from the beginning. They have just done a report sort of trying to figure out what the Medicaid expansion would mean for them, and they've already found that it's going to save them $372 million from 2014 through 2022. So I think we're gonna look for more reports like that, and as states really do the math to push that math and to say this is a good deal for you. This makes sense from a public health perspective, but it makes sense from an individual health and from a cost perspective.
Do all of you understand the DSH issue, the hospital issue? I saw a couple of blank looks out there. If
you wouldn't mind just elaborating on it.
I will let my lawyers over there to remind them. But it comes up because, the DSH payments are going to go away, the disproportionate share, so that the safety net hospitals who've gotten increased revenue because they take care of the uninsured, that part of the law is holding. So if you're in a state like mine in Kansas, the DSH goes away, but the Medicaid expansion doesn't, those hospitals are still going to be taking care of patients who don't have any mechanism of pay. And part of the reason they bought into the ACA is because of the Medicaid expansion issue. So as you kind of alluded to, the hospitals and the doctors have not always been aligned in what they wanted from the federal government, but I think in this particular arena, getting your local hospitals and hospital associations support to go to the legislature and the governor with you makes a lot of sense, because it's going to cost a lot of money if indeed they let the Medicaid money on the table, and then they still have to take it in the teeth over the lack of disproportionate share.
Okay. So I'm going to shift slightly in terms of coverage options to the insurance exchanges. I'm sure we'll come back to Medicaid as well, but for folks that are over the Medicaid eligibility level, 133% all the way up to 400% eligible for tax credits that they can use to buy insurance in the exchanges. So, Amy, if you can talk from a state point of view, just what role AIDS advocates and their caregivers can play in the creation of these exchanges, but then a little bit maybe just about how the exchanges could play a role in people's ability to get HIV care from their providers of choice.
Sure. So, yeah, I mean, the exchanges are a huge piece of the Affordable Care Act. If you've got the public insurance expansion on the one hand with the Medicaid expansion, the private insurance expansion really comes through these state exchanges where people can get subsidies to purchase private insurance, and they're regulated exchanges. So I think, that there are a couple of things to say. a lot of the details of what these exchanges are going to end up looking like have yet to be written. We're still seeing them. States have the option of running their own exchanges. I think about 15 or so have made the decision or passed legislation or executive orders to put in place a state-based exchange. And for states that do not want to operate their own exchange, the federal government is going to operate the exchange for the state, or some hybrid partnership model where the state will take on some functions. So that is all to say, I think that these exchanges are still being built, and we don't know exactly how they're going to work for anyone, never mind for people living with HIV. And that's a challenge, but I think it's an opportunity on the state side to really make sure that, just take out like the benefits package, number one, to make sure that the benefits that people are entitled to through the private insurance plans, through the exchanges, are able to meet the care and treatment needs of people living with HIV and other chronic conditions. We've gotten some federal guidance on the essential health benefits package. That's the 10 categories of mandated benefits that have to be included in every insurance plan sold through the exchange. But that guidance has indicated that there's going to be a whole lot of state flexibility. So I think from a sort of advocacy perspective, really trying to shape and influence that process. If your state has the choice. So every state has a choice between 10 plans to be its benchmark plan, and that's the standard for the scope of coverage that's going to be offered for people who get their insurance through the exchanges. So it has to include these 10 categories, but they're really broad categories. So I would say that one of the most important sort of advocacy points and implementation points is to make sure that those benefits packages are expansive enough to meet care and treatment needs. So just looking at prescription drugs coverage, I mean, that's huge. And the federal guidance thus far has not been so great in terms of making sure that every plan includes a robust prescription drug plan or coverage. So, there are, I think, a lot of issues with the exchanges, and I think California is dealing with a lot of those. So I'll end it with the essential health benefits, because I think that's going to be huge. It's something that's moving. States have to pick their essential health benefits benchmark plan for private insurance sold through exchanges by September. It's a really big deal, and it's gonna impact. We've got access to insurance on one hand, but we need to make sure that access to insurance means access to care, and the benefits really dictate what that means.
So rather than pointing at people, just if folks want to add to that, just jump to the microphone and pick up on those issues, or add other things that advocates should and their providers should be putting on the table.
Yes, so I'm living and breathing this right now, so I can't agree more. It's so critically important to have HIV care expertise at the table. And I think the message I wanted to bring here more than anything else is that nobody's going to invite us to that table. We have to insert ourselves in that process. And, we've been fortunate in California that we've built up really good working relationships with other low-income healthcare providers and low-income health advocacy groups and other complex chronic conditions. So we just continue to try to bring HIV to that conversation, and we've found that that's been a really strong partnership for us, and it's critically important. But again, nobody will ask you to come to these meetings. You just have to show up, and you have to keep saying HIV, HIV, HIV. And hopefully somebody will hear you, and again, responding to regulations. And I know that for a lot of you, this might not be as relevant, but I think making sure that there's somebody that's looking at the regulations that are coming out, and making sure that things like Amy mentioned in terms of the formulary really addresses the needs of people with HIV, the provider networks, how we, one of the things we were surprised about with the Medicaid expansion, for example, was how we define network adequacy is very, very different. And so just having access to an ID doc, for example, doesn't necessarily mean you have network adequacy. So how are HIV providers identified in the networks, and how can we make sure that that really meets the needs of our population? So I think that's my main point to bring to this conversation.
Yeah, and what I'm hearing also is that obviously in states that have, let's say, recalcitrant governors and legislatures, it's vitally important to try to push and advocate. But even in states that traditionally have been very progressive and very forward-thinking, they have to make a lot of decisions in the next 18 months, or actually 12 months, because these exchanges have to be up and running by October of 2013. So don't assume that they're going to get this one right if there are issues that they need to address, whether it's adequacy or benefit package, to make sure that there's at least one or multiple voices that represent HIV providers, HIV patients in that discussion, because it's unfortunately fairly easy to make what seems like a small mistake or a small oversight in putting these things together that will affect how you operate, how your patients get care. So I think engaging in that conversation over the next year is really a significant role that you can play, as well as the advocates for patients nationally and state. Donna.
And I think turning your providers, I mean, the people here are obviously involved and interested, but you have a lot of providers, HIV providers, who are just in the trenches doing their work, and they're not really thinking about this. And they need to be brought to the table, and they have to be willing to participate in these networks and exchanges and plans. They have to fight for the ability to be in the plan, because if their patients are suddenly taken over or find a good exchange plan that they want to be in, but they're not in it, the continuity of care is gone, and those patients are going to have to come up with new doctors. So I think we have to have the provider network involved now, trying to say, yes, we want to be a part of this. How do you keep us to be a part of this? Don't exclude us.
Jeff?
I just want to add quickly, we also, this can seem overwhelming and there's all these technical details, but we're not starting from zero. You know, we dealt with these issues with the transition to managed care. I'm reminded in the late 90s, Sarah Rosenbaum of people at GW did all this work on contracting specifications. And when Jen Cates first went to the Kaiser Family Foundation, one of the first projects we worked on together was a consumer guide for a specific contract language about managed care contracting for people with HIV, dealing with network adequacy. So we have some of these tools that we need to dig out of our files to help us sort out some of this stuff.
Good point. Good point. Let me shift to, so implementation proceeds, the benefits start becoming available. A lot of people with HIV/AIDS, particularly who have relied on getting their care wherever they can, aren't going to be able to spend the time and energy to study up on all of this stuff. They'll need to learn about the new benefits and the new rights that they have. What role can their providers play in making sure that people who now have new benefits and rights, at least by statute, know about them and can exercise them? What are the sort of key worry points on those issues?
Well, for those of you who are providers out there, you know that you're the one that gets asked. Remember when Part D came out? How many of you spent a lot of worried time trying to figure out what to tell patients that wanted to know which Part D plan they should sign up for? I learned a lot more about it than I ever wanted to know. But I think we're going to be in the same position. We have to be able to know what's out there, whatever comes down the pike, and be that source of information. For those of us that have the luxury, at least right now, of case managers, a lot of that can be shifted to case managers. But there are people taking care of HIV that don't have a lot of case management. But I think the providers have to be the ones that figure out how to educate their patients or know where to send them, because we are the ones that are going to be asked.
Just to add, I actually think that providers need the education first. I mean, I think it's so complicated, and those of us who are focusing on it still are, you know, I have my resources that I go to daily to try to remind myself of all the nuances and intricacies of this. So educating providers, such as through this and through the Academy and through HIVMA and through AETCs and through, you know, other parts of HRSA, and not just HRSA. I mean, really finding the right ways to educate providers is critical. And I think, on the one hand, it seems like an overwhelming task. On the other, I think there's some targeting that can be done, because we're really talking about if we want to reach the maximum number of patients, there's probably a subset of places to start that education.
Jeff.
I just want to echo that. You know, some of this, you know, my former job, I remember a close friend and advocate coming in and talked to me, and they had this long list of all the things that people across the government, including CMS and HRSA, were supposed to do for them. And I think it's fair to say that CMS and HRSA should be doing things to help this transition. There's things that should be happening at the state level. But nobody should have a reasonable expectation that this is all going to be served up on a silver platter. And like Donna said, the questions come to you. So you also have to do your part, and you are the experts in your community. And you should look to federal resources to help you, but don't wait for them to do it. And part of me is shaped by this experience I've had of being on the inside, where I was not critical to the implementation of the ACA, but I was part of the team. Twice a week, I'd go to very high-level meetings and just saw how everybody, at not just Health and Human Services, but 3 departments, Department of Labor, Treasury, were working like 14 hours a day, every day, for years to do all this stuff. They are working so hard just to do the basics of implementing this law. And it's incumbent upon us to think about the other things and ask the questions, as Courtney said, what about HIV? What about HIV? So again, expect resources and support, but you all have a big part in making this work as well.
I just wanted to add, I think it's for those of us that have sort of Ryan White Part A planning councils, that putting that question to them is really important as well. And what we've been talking about in San Francisco is how are we allocating our resources now that we do have some of our primary care taken care of by these low-income health programs? Is there Ryan White money that we can reallocate to case management? And so far the answer has been no, but it's my hope that that will be an area that we can really invest in, and really making sure that we know, we define what that type of case management or benefits counseling is and what those people need to do, and what does the curriculum look like to get those people trained. And I don't think we need to reinvent the wheel there. I think that there are a lot of areas that we can look at, but these are conversations that we're really hoping that we'll have at a national level, but we're starting in San Francisco now. And then one other thing I wanted to mention is in California, we've also started, sort of by necessity, a stakeholder advisory group with our State Office of AIDS and our Department of Healthcare Services, mostly focused on how transition is happening on the ground now, because we are transitioning folks off of Ryan White. But as part of that process, hoping to look long-term toward 2014, because we're then, of course, going to have another transition, and what kind of communication networks can we set up now? How are we communicating with our HIV providers? Because we realized through this transition, we're not doing that very effectively now. And so that stakeholder group involves, again, government folks, but then also advocates, consumers of services, and providers. And we meet on the phone once a week right now to talk through these issues. So just wanted to mention that.
Yeah. Just real quickly, too, I mean, we have to think about the scope of what we're doing. We're talking about 500,000 Ryan White clients that are going to be largely transitioned. And we also need to think about triaging. I mean, I think we need to think about sort of 3 levels. A lot of people will get by with information or group education. Some people are going to need one-on-one assistance, and I think there'll be some complicated cases where people will need legal assistance. And I think in local levels, we need to think about how we're meeting the need. But there's no way we could give everybody a lawyer to get through this. And we really need to minimize the people that actually need one-on-one help, but some will need that. So.
I'm going to actually go off the schedule here a little bit and I'll open up for some questions now, and then I'll pick up with some other issues. So if folks can go to the microphone, gentleman in the front row was definitely the first, and then we'll take a few questions and then go back and forth between the 2 formats, if that's okay with folks. And again, if you can tell the audience who you are and where you're from, it helps everyone with that. Sir.
Good afternoon. I'm David Schmidt. For about 20-odd years, I practiced primary care HIV in Miami, just moved to Charlottesville, Virginia. One question that I have for the panel that doesn't have anything to do with Charlottesville, but in really an astonishing act of equivocal behavior, Congress has put forward this notion of across-the-board cuts. We're talking about expansion of social services, and I'm wondering whether anybody's really taking seriously the possibility that there will be across-the-board cuts in funding for healthcare, HIV in particular, but in general, and what the impact on the expansion this will have. And the second question I have has to do with something I noticed when I moved to Virginia. The majority of care for HIV in central Virginia is provided by infectious disease people, principally through UVA's ID clinic. I don't know what what ID providers are, what their feeling is and their support of Medicaid as a source of revenue. Certainly the university will accept Medicaid, but I don't know how many private infectious disease consultants will. And I'm wondering whether in that area there's going to be a further decline in primary care, comprehensive care for people with HIV because of what seems to me to be an inevitable shrinkage of infectious disease participation. And I just don't know to what extent the IDSA is involved in this conversation. I know I brought up three issues, the funding issue, the Medicaid and specialists, and the participation of our ID colleagues in this matter.
Okay. Who'd like to start us off? Jeff?
So I'll start with the first question. I mean, what you've raised really gets to sort of like what's a looming budget crisis at the end of the year and the potential for sequestration. And we could all, make ourselves sick worrying about what's going to happen. I don't think we really know. As it's structured, Medicaid cuts are sort of protected at the moment, but who knows how that'll play out. I think a lot of people hope that after the election we'll get some sanity. I think there's been a lot of consistent economic analysis that it really would be bad for the national economy if we implement these cuts. So I think we need to hope it doesn't happen and engage in the political process. The thing that's most worrisome to me is that the deal that they did strike that calls for cuts was pretty balanced between defense and non-defense. But if you read the news lately, you're only hearing a pushback on one side saying we can't make these defense cuts. So I think we need to start and make the case for why we also can't make these social service cuts and cuts in pretty much the rest of the budget. But I don't really know, like when people ask me these questions, I want to give specific advice on things we can do. I don't think we know enough now to really know how to respond to that. But you're right, it is worrisome that we're trying to take a big step forward with the ACA, and this could be really a step back.
I should know the answer. I'm going to come back right back to you. I should know the answer to this question, but is Ryan White protected from the sequestration?
No, it's not.
So what size sequestration is
There's
set?
something in the paper this week that suggested about 12,000 ADAP clients could lose services. It's just one sense of the scale. I mean,
yeah, I mean the general percent cited as a 7 to 8% decrease over the current,
7 to 8%.
And it's imminent.
Further decrease of the current levels of funding for all programs generally. So that would, Ryan White included, CDC
AIDS
prevention included,
research, etc.
And
global AIDS included.
And the issues that Dr. Sweet brought up about the inability to recruit physicians to do this work is going to be further impacted by those cuts, which are imminent. This is a Damoclean sword that is there now.
Courtney.
Yeah, just wanted to add that, not to be too doom and gloom, but we're also seeing this. I mean, we're operating in a budget deficit environment in the state, too. And so we're trying to do all these sort of innovative and creative things with no money, and in the face of other cuts to our social services from the state perspective as well. So I definitely hear what you're saying, and it's a struggle on a daily basis. But I think it is something that we responded to really strongly last year as an advocacy community around seemingly very similar situation last year, and it seems like we need to step it up again this year. But it's always a challenge, as you mentioned, to really figure out when and where to engage and how to really be effective in our advocacy.
And to answer your ID questions, AAHIVM is here, IDSA is back here, and they've been very involved, as has the Academy. But one of the things that I have been involved with and through Health HIV is trying to get more primary care people who are very good providers involved in HIV care. It is not what it was in the mid-90s. We all know that. There's still a need for ID specialty at some points, and for ID people who want to do this and sign up for Medicaid, that's fine, but I think there might be a dearth of those. So trying to get where the new money is going, which is the FQHCs, the CHCs, and try to get some of those very good clinicians more involved, and truly, they're supposed to be based on a medical home model. That's the way the FQHCs are supposed to work. If they're a medical home, they should be a medical home for all of their covered lives, and they shouldn't be able to exclude HIV care just sort of automatically. So we're putting together kind of a workforce plan and trying to do some mentoring so that for some of the FQHCs that are interested or have an interested provider, we can give them the expertise, help them develop the information and other things, and be mentors so that they have somebody to call on. All of you know, I think, that the hardest thing about being a sole HIV provider in an area is being the sole HIV provider, not having somebody to bounce things off of. So if you can give people some support, then very good people might learn some improved skills, and we might mitigate some of this workforce issue. But I think that your Virginia model is true in many places, and I don't think a lot of outpatient ID people are going to want to continue Medicaid rates for a great deal of their care. So I could be wrong, but I do think that it's important that we continue to try and educate people that are in the healthcare homes where these patients are supposed to be going, we can get a few more of them to take care of them with our help, then we will continue some of the very good care we've been able to give people with HIV.
Can I just add one quick thing? The Medicaid, there's the increased primary care rate in Medicaid under the law as well, which is 2 years, but clearly sort of the push, at least in California, and I think this is a nationwide trend, is for people with HIV to move into more primary care settings for their majority of their care. And so it's also critical that as we talk about what that looks like, that we have HIV care expertise in those dialogues as well, because that's going to be clearly where we're moving, and we just want to make sure that's done well and with providers that have some HIV experience leading the way.
Related to that is the issue of having an HIV specialist count as a primary care doctor to be able to access those enhanced rates, since in many cases the HIV specialist is serving in that function too. So.
Right. Can I just add one thing to that point?
But just for those who don't know what the primary care increase, can somebody just quickly describe what the 2-year provision does?
Well, you get Medicaid rates become Medicare rates, and many people don't like Medicare rates. So it's, I mean, it's a bonus, but it's better than just Medicaid, but it's still just Medicare rates. And then there's the 10% primary care on top of that. If you are a primary care specialist who's, 60%, 70% of your billing has to be the appropriate E&M, 60%. 60% of your billing has to be the appropriate E&M code. So if you're much of a procedurist, you get knocked out of the primary care 10% pretty quickly.
So, and just to clarify on that point, so it's limited, right? And I think everybody would agree that it's not the best. But Medicaid reimbursement rates certainly a barrier to getting providers who are qualified and are willing to see Medicaid patients. But I will say one sort of good thing about the regulation, it went a little bit further than I think people expected it to do in sort of expanding the world of who's going to be eligible for that enhanced rate. And again, the Medicare rates are still not great, but they're better than Medicaid. So what the regulation says is that if you're a primary care provider with a specialty designation of family medicine, general internal medicine, or pediatric medicine, or subspecialty, you're eligible. And then if you're not board certified, there's another way to figure out if 60% of the codes in the past year that you've billed for are for primary care evaluation and management codes, then you're eligible. So I think it was better than people expected it to be, and I think it's still going to be work to make sure it's implemented in ways that incorporate the expertise of HIV providers.
And which 2 years are they?
It's 2013 and 2014.
Okay, thank you. Gentlemen? No. Thank you.
Since transitioning from public to private care, I have been made acutely aware that there are several layers of Medicaid. One is traditional Medicaid, the other is managed Medicaid. Managed Medicaid does not pay their bills. In fact, we've had to drop to levels of managed care programs because just in traditional family practice, they weren't paying their bills on time and have refused to pay. And then we've lost several $1,000s on procedural payments. And in the last 2 years since I have transitioned into private care, a lot of the local Ryan White personages are being transitioned into Medicaid services, and I am getting those people. But they're having a hard time with the formularies and the types of programs that they're being either forced into or told that they have to go into or choose from. So as providers, we need to be aware of those programs that are offered in each state. We have ICHIA, which is an Indiana high-risk insurance pool managed by Anthem that was traditionally covering what wasn't covered by traditional insurance for the high-risk populations like HIV-positive people. Then there's traditional, which paid, you could get on it. It took you a long time to get on it, and once you got on it, they took care of everything. And now there's managed care Medicaid, which they don't pay, period. And the formularies suck. And the reimbursement is even worse than traditional Medicare and Medicaid. So as providers, my point here is you need to be aware of the programs your clients are being transitioned into.
And I just want to thank you for that point, and that is what we're experiencing in California is all of our seniors and persons with disabilities, which includes all of our people with HIV that are in fee-for-service Medicaid, just transitioned into Medi-Cal managed care. And so as we look towards 2014, that expansion population, at least in California and I think most other states, it's going to be a managed care plan. And so that's why I was trying to make the point earlier about what that plan looks like is so critically important, and what the formulary looks like and what the network looks like. That's all what's being decided now, and that's really where we need HIV providers to be informing that process.
And again, we're back in the same old position. What happens when a lot of providers refuse to even take Medicaid? You're back needing a program similar to Ryan White. So it's a big Gordian knot type situation. You're darned if you do and you're darned if you don't. And it all stems on whether the providers will take Medicaid coverage in what they provide.
And I would just add that yes, I agree, but I don't think it's all as doom and gloom as that, and maybe this is, again, just my California perspective, so please take this with a grain of salt. But I think that we have a real opportunity here, so I do think this is a challenge, but it's a real opportunity to design the system that we want, right? We're not asking about a technical problem. This isn't something that we can fix. This is really new thinking, and how can we make sure that the system we create takes care of people in the way that we need it to take care of people, and then working with people like Jeff about what does Ryan White look like in this new environment, and how can Ryan White fill in the gaps, and how can we really create a system that supports people to stay in care that we know they need. And so there are, California's we've had a lot of challenges, but I think that there are a lot of things that we've done right. I think Los Angeles County, for example, and how they've set up their low-income health program is a model that we might want to look at in terms of how they define things like case management and mental health care and substance abuse care. And some of that we want in the network, right? But as HIV providers, some of that we don't want in the network, because that means we can continue to use Ryan White to cover those services. So how can we be creative here? And given that this is where we're moving, how can we make the best of this opportunity is how we're trying to approach it in California, kind of just because we have to, because that's where the train's moving. But I do think we can't understate the benefit to clients when they successfully transition into these new coverage. We have seen, even in San Francisco, where we had pretty good access to care already, clients are seeing great improvements in their access to care and what services they can access. So I don't, I know that it's scary times, but I don't want to sort of forget about that part of it either.
Okay. Our next question.
Great. My name's Tyler Termier, and I suppose I'm here wearing 3 hats today. One as the Executive Director of the Ohio AIDS Coalition, another as the Chair of the Board of Trustees for the National Association of People with AIDS, but most importantly as a 29-year-old black gay man who is living with HIV over the last 9 years of my life. And I don't know that I'm going to ask a specific question, but more so highlight a couple of things that I've heard today that I think are not necessarily going to be earth-shattering to anyone in this room, because we all are following the issues, but are some of the real issues that that myself, as someone living with HIV, as well as the clients that I'm working with in a state like Ohio, who is also wavering on whether or not they should expand to Medicaid, faces. I think, Jennifer, you made an amazing point by saying first we need to educate the providers. I run an organization that is solely charged with educating both providers and clients in both leadership and education opportunities every day around the year. But our providers are lost, and they have, I think it's taken so long for so many of us who are following these issues to feel even remotely comfortable to talk about them in a setting like this, but try and get a group of providers who already have too many patients on their docket, or case managers who are going to be expected to explain these things to clients who already are seeing 100+ clients on a regular basis in a room, to talk to them about the nuances of what these programs are going to mean and what the road ahead looks like. So I guess I challenge us all to think about beyond just saying we need to figure out how we translate to the local level, but really engage in a national conversation about what it really is going to mean to make that happen. And I think the National HIV/AIDS Strategy is a great example in that it's a wonderful document, and great things are happening in many places. But then take a place like Ohio, for example. The National HIV/AIDS Strategy is that good old strategic plan that's sitting on a shelf, compiling dust, because providers and community-based organizations have no idea what it means for them at the state level necessarily. And I think there's a lot of people who have responsibility in order to make those things come to fruition. I'd also say that I think we're having a really great conversation today about what this road looks like as we travel towards 2014, and that we have a lot of challenges, but it's also a really amazing opportunity for us to design what the systems are going to look like. But beyond just figuring out how we're going to get providers at that table, I think it's crucially important that we figure out how we are going to have the meaningful involvement of people living with HIV at the table and in these discussions. I think, for a long time we have struggled with trying to figure out how we just get the greater involvement of people with AIDS and just get someone that can sit at the table, that can fulfill requirements within our community planning structures or within our national conversations. But what does it really mean to have meaningful conversation of those people who are living and breathing this disease every day and are going to be impacted so greatly by this? And beyond that, how do we translate it to, all of this to the local level, not just so that providers can understand it, but so that those providers can best educate the clients that are going to be impacted. And I think one of the greatest challenges that I have, I just spent the last year and a half working on the national level, and now I'm back at the state, and I've seen, I've lived both worlds, so I know the challenges, and I'm trying to help a state that is greatly in need of the major reforms of the Affordable Care Act. But the people in my state have no idea how to navigate this system. And I have people from my state health department calling me, asking me questions about the Affordable Care Act and what it will mean. And when I challenge them back about having someone working on it at the state level, they go, "Oh yeah, we don't have anyone working on that at a meaningful level at this point. We don't really know how to navigate this system." So I think that the conversations are happening, but there's still so much we need to do to empower our state health departments and our community-based organizations to involve people with HIV in the process, but also for our national organizations to be providing the resources that are going to be condensed enough, which is, I realize, a challenge, but condensed enough and useful enough that a provider will have the time to read it and then educate the clients that are going to need this information the most. Thank you.
Thank you. Reactions or comments?
I have
Courtney?
I have a lot of comments, but I definitely feel your pain, and I am in a similar situation, I think, in our state is obviously more further down this road, but we get questions from our state all the time. There's a website called HIVhealthreform.org, and we do webinars once a month right now on sort of the nuts and bolts of healthcare reform implementation at the grassroots level, what it means. As much as anybody wants to participate in those are open and available, and all of the webinars, I believe, now are on HIVhealthreform.org. You can listen to them from, I think we started in January. So that's about 6 months now worth of webinars that we've done. There's fact sheets and information on there that we're generating and presentations that you can use if you want to give presentations about what health care reform means and just need a presentation to use. Please, they're there, they're available. And then also, I think as much as you can, if it's possible, again, I mentioned this task force that we've just started getting together on a weekly basis right now because it's so pressing, but even on a monthly basis, just talking through some of these issues. There is nobody that knows these answers, and that's what I found out. It was really sad to find that out, but it's an opportunity for us to really figure out what this is going to look like and what this means, and obviously cannot be done without including providers and people living with HIV in a very meaningful way. And so that's what we're trying to do, and it's a challenge, but we're doing it every week. And then also at the local level, having a similar task force that meets monthly, just talking through some of the nuts and bolts, because it really will be implemented at the state and local level, in terms of where clients interact with the services. So that's really a big area of focus.
I just want to take this time to plug what she's talking about. There's a FAPP, and if you're not involved and you want to be more involved and hear what's going on, get on some of the calls. It's the Federal AIDS Policy Partners, FAP. But there's two work groups that I listen to every time they meet, and that is the Healthcare Access Working Group and the Ryan White Reauthorization Working Group. And there's over 100 organizations, and it's all of these very bright people that kind of follow all of this. So it's a way of getting on and trying to listen to what's going on every month and sometimes every couple of weeks. So if you're not involved in that and want to be, you really should kind of contact somebody, but it's well worth your time if you're really going to try and understand it locally.
Our next question.
I'm Keith Barton, and I'm from Oakland, California. I worked in the AIDS clinic in the county jail in Alameda County, right across the bay from Courtney. And my impression is that a high percentage of the people with HIV in corrections, jails, and prisons, by and large do not take medication when they are out of custody. A relatively low proportion of them take medication. And even though I made extra efforts to refer them to the Ryan White clinics in Oakland, my sense is that relatively few of them went. I just want to bring this to your attention that there is a large proportion of people with HIV who do not even take advantage of the Ryan White facilities that are available. And obviously, this contributes to the transmission of HIV. I believe the figures are about 20% of people with HIV pass through corrections at some point in the course of a year. And the incidence of HIV in corrections is about 2 or 3 times what it is in the general population. So it's a significant population for people to be aware of. I'm currently doing policy work in New Jersey, and I'll say that the AIDS Coalition of South Jersey actively goes into jails to meet with people and get a face-to-face interaction with them. And I think that's a viable strategy for trying to bridge this gap. Another thing in terms of bridging and coalition is that I suspect a large reason that people don't take HIV medications is that that even though they could access them through Ryan White, they are dealing with addiction problems, and that that is another category of services that we need to be actively involved in bridging and making available to people with HIV.
I just want to respond quickly. I think you point out a real weak spot and something we need to address, but I think the federal agencies are aware of it. I think HRSA is doing some work in this area, SAMHSA and the Bureau of Prisons, the Department of Justice are all doing some work specific with people with HIV. So,
all right. I want to make sure we get to all the questions, so I'm going to ask for short questions and short answers to make sure that everybody gets at least a chance to ask their question that has one. Sir?
So my name is Keith Rawlings. Spent the last 20 years in practicing medicine in Texas. And one of the questions that I have is that the variant in Medicaid program coverage is all across the board. And while expansion in California, while wonderful, will get you to one level, expansion in Texas, Louisiana, Mississippi will get you to something very different. In those situations where you particularly have those states that have low Medicaid either reimbursement or Medicaid coverage, because in Texas, for example, three drug coverage for a Medicaid patient, independent of what you have, is very different than unlimited coverage, say, in Massachusetts. How will the Affordable Care Act address that kind of disparity that already exists within the context of the Medicaid systems, even if you expand it? And are we not just simply saying for those who are HIV positive that you need to move to California if you live in certain states? The other question is, and this I think is really just specifically aimed at you, Jennifer, can anyone tell us a volume of individuals that we're anticipating in the HIV world that would be moving from Ryan White into the Medicaid structure to get some idea on a national level what this actually might entail? Or, I mean, we talk about it from the local level, but what kind of volume are we actually talking about?
Okay, thanks. Jen, you want to start us off?
Sure. Just on that second question, and on the, well, actually on the first question, might not answer it completely, but I think one of the downsides of the way that the Supreme Court ruling happened is that before, with the ability to enforce the new category, there would have been a floor across the country of 133% FPL. And while that floor, and that in many places would raise the bar, in other places they're already above that. So, but I think that has presented it will still could get better in a lot of places, but there'll be a variance, and that's a real challenge. On the second, I will say that we at Kaiser are doing those estimates now. It's a lot harder to do after the ruling because we could say, we're looking at, well, if all states were to do this, this is what it might look like. So there's not going to be any magic here, and it's not as easy as just saying everybody on Ryan White or everybody in this place. And one of the challenges that we're running up against, and this is not a surprise to anyone here, is there's no single data set that really provides an easy answer to this question. And so we're looking at different data sets. I know that HRSA is looking at this question, and ASPE is looking. I mean, a lot of organizations are looking at it. It's not a simple one to answer, but it's an important one to answer.
Yeah, and
Amy.
just to add a note to that, to the first part of the question, I think the advocacy community writ large was really hoping for more of a federal floor across the country so that you wouldn't have such variation in the benefits that people are able to access, whether you live in Texas, California, Massachusetts. And that unfortunately didn't happen. And I think what we're seeing a lot more of is that there's just way more flexibility on the part of the states to implement the Affordable Care Act. And so just looking at the benefits provisions and just looking at the benefits provisions for Medicaid, so we've got some standards, the essential health benefits, those 10 categories, same 10 categories that are required for the private insurance plans and exchanges are going to be required for all the newly eligible beneficiaries in Medicaid. So that's huge, but what does that mean and how does that get implemented? And what I think we're going to see, states are going to have a lot of flexibility to pick the plan for their newly eligible beneficiaries, and I think that there's going to be sort of a knee-jerk reaction in some states to have that plan be less comprehensive than we need it. And then we've got a state advocacy issue. And just to bring out Texas, for instance, certainly that's a state where I think the advocacy is more challenging than in other states. And just, 3-4 months ago, there was a major decision about whether to move or to have the 3 prescription drug limit that's currently for fee-for-service, whether all the managed care organizations were going to have that 3 drug limit in prescription drugs. And, that was an opportunity for HIV advocates who are in the room to get together with all of the other advocates and people who are going to be directly impacted by that and say, this is crazy. And it doesn't make sense from a public health or individual health perspective, but it doesn't make sense from a cost perspective, because what are you going to do with all those people who need far more than 3 prescription drugs per month? So I think that's just sort of an example of where these advocacy fights are going, and that's going to happen in Texas, and that's going to happen in a lot of these states, because at the end of the day, those benefits decisions, a lot of times, they're going to be taking place in state Medicaid offices and state legislatures.
Jeff.
I just want to add quickly on that. Those are the kinds of battles that do need to happen at the state level, but we can win. There's been a really worrisome trend, specifically on drugs, a number of states imposing limits on drugs dispensed. A number of states, though, have exceptions for ARVs, for example, or they have other exceptions for mental health drugs. I think most legislators, they don't say, we need to do this because we want to keep these people with HIV from getting their meds, because they generally see them as being cost effective. But it often does take education, you know, so I just think we can win some of these fights if we engage.
I just wanted to add quickly that Texas, I think, has some really fierce state health advocates, and I believe they now refer to themselves as the honey badgers. So I wouldn't count Texas out yet, and they are working really hard on the ground to make sure that that program is as good as it can be. But I also think that your question raises the point that Ryan White is not, the need for Ryan White will remain even after healthcare reform is implemented because of the variation in programs from state to state.
Next question.
Well, I just wanted to share my experience to follow up sort of on what Jeff said in some of this conversation. You know, and I'm from Arizona. I'm Kevin Carmichael from Tucson, Arizona. Arizona was the last state to get Medicaid, and it's always been a managed care plan. And so I think what we need to recall is that we have a lot of power. We as the providers and we as HIV advocates, when we get into a managed care environment, those managed care plans are responsible for our patients. And we can spend a very large amount of money if we let people get sick. That money is going to have to be spent. We can make the case, there's lots of data to support that taking good care of people with HIV saves money to the plans. And that may not resonate too well with a legislator, but when you're talking to a medical director, it really resonates with them. And so I think we have to have our advocacy at multiple levels, but in some ways, a managed care environment is actually a very good one for us if we do our homework and really go to the medical directors. And I've been generally successful when I go to a medical director who initially they deny me a drug or deny me a test or whatever, and I go back and I tell them why I want it, and I try to be, I'm actually fairly reasonable usually, and generally you can get what you want if you can prove and if you work and let them know you're trying to do the best for your patient and you're trying to save them money as well. So we do have a lot of leverage here. I mean, it's a gloom, you know, we hear a lot of uncertainty and people are frightened, but we do remember we do have a lot of leverage, and so I want to maybe interject a ray of hope there, and managed care may not be a bad thing for us. It may actually be really good for us.
Okay.
Thank you.
Thank you. Yes.
Hi, I'm Ann Bagchi, and I'm like the other person. I'm kind of here wearing several hats, one of which is that I'm a senior health researcher at Mathematical Policy Research, and we're doing some research kind of on this topic. I don't think I can say too much about that, but one thing I did want to follow up with what Courtney was saying, and to, in a way, I guess, kind of convince people in the room that it really is an issue. But this whole thing of being at the table and not being invited to the table, I'm actually hearing states actually kind of saying almost as if it's a good thing that they're not bringing people to the table. It's like we don't discriminate. They think of HIV as the same as any other chronic condition. So we're not designing things with HIV in mind because we want it to be the same for everybody. So we're not discriminating. And so that's, and I just wonder kind of too, as a question, how do you address that kind of way of thinking?
Well, I think that if you tell them what happened in California when they forgot to bring or wouldn't bring people with HIV to the table, that hopefully that'll start the conversation. What happened in California was that because people with HIV were such a small proportion relative to the overall population that was being considered, we didn't rise to the level of needing to be at the table from their perspective. But what they weren't understanding is that we bring with us this Ryan White money, this $2.4 billion federal appropriation, and they really didn't understand how that program worked at all, and to a large extent still don't or have a lot of questions about how that program works. So in the end, that ended up being a lot of our power, is that we were really going to be impacting their systems of care because of the money we bring with us. So I don't think that that's the ideal way to get in the room. And I should just add, I mean, this is in California where we have very good relationships with our Department of Healthcare Services generally, or we did, and I hope we still do. And even then, they didn't really think of us. So I can't overstate enough how much you just have to insert yourself and just keep coming back. And even if you're a pest, it doesn't really matter because I'm one too, so you're at least in company. But yeah, you just have to keep inserting HIV.
Yeah. Two other thoughts on that, and one is one we've been saying for a long time for those of us who work in HIV. If you can't do it right for people with HIV, you're probably not doing it right for a lot of people. So it provides a way to say, This isn't a self-serving thing. This is really about a population that we've learned a lot about treating and access and many issues, so it would be in their interest. But secondly, I think another newer way to approach it is with new research showing the incredible power of treatment as prevention. It really shows the public health implications of getting people with HIV on and treatment and access as much as possible in addition to the clinical one, and it provides a new argument, I think, for why a state should be interested in thinking more seriously about this.
Thank you. Yes, sir.
Hi, I'm Andy Cates, and I am from California, and I'm an advocate. And it seems like California is being painted as somewhat of a Garden of Eden in a sense, and it is a little bit bumpier than that. There's people that I know that I advocate for that in the Medi-Medi shuffle have been shoved into care situations with physicians that have no experience with HIV. They've got very complicated scenarios with complicated medications, opportunistic infections, and they've been sent places that are dozens of miles away from where they actually live, and they don't even use transportation, or they don't even have transportation to get there. So, I mean, a personal story is I got shuffled. I'm a guy. I mean, I don't think I look too female, and I got shuffled to a gynecologist. So that's how ridiculous it can get, and that's troubling to me. And if California is as forward-thinking as we all think it is, and we're leading the way to, follow us, we're doing it great, that's a problem. And in respects to what Donna was saying, I think when you talk about shifting care of HIV-infected individuals, spreading the wealth or whatever you want to refer to it as, to general care practitioners that maybe don't have the experience, I think there's a step that is skipped as far as bringing them to the table. They won't even ask, independent of guidelines, for an HIV test right now. They're scared, it's icky, they don't want to talk about it, and it's definitely not table talk. So I think, unfortunately, the challenge is just to get them to open the door.
And I certainly didn't mean to paint California as a Garden of Eden. I mean, we've been struggling.
She hasn't been doing that outside of this meeting.
That was not my intention. We've been struggling with the transition to managed care, and it's been extremely frustrating. Clients getting shifted into pediatric clinics, and it's not just us. I mean, it's not just people with HIV. It's cardiac patients. It was very much an example of how not to do a transition of a vulnerable population. So that's what I'm trying to help people prevent. But I think it raises a very good point around what are patient protections in the process. And it's something we haven't really talked about that much here, but it's critically important. The patient protections that were in that transition that did exist completely broke down. So it's something that from an advocacy perspective and from a provider perspective, we need to pay a lot of attention to. And then I had, and it's the network adequacy thing again, and how do you define, when we were talking to Department of Healthcare Services about that, they didn't understand that someone with HIV needs to see not necessarily an HIV specialist, but somebody with HIV care expertise of, some definition, and that they didn't even know that. So again, that's in California, and I think it just points out that we do have a lot of work to do, but I don't want to make it so doom and gloom that it's unattainable. I mean, I think it is something that we can strive to achieve. It's just something that we all need to learn from and figure out how to move forward. But your point is very well taken, and it has been a really rough couple of years for us in particular.
Okay. Our last question. That's you.
I have a comment which actually comes on the tail of that comment pretty nicely. My name is Christian Ramers. I'm at the University of Washington in Seattle, the other Washington, and I work at the Northwest AATC also, and I'm very interested in this issue of who is going to be the one that assumes the role of caring for HIV. And so I'm the medical director of a telehealth program, which is sort of a new model, and it speaks to what Dr. Cha said about this being an opportunity for innovation. We got a HRSA grant to start providing telehealth support to FQHCs that were willing to take on some HIV. And the model is that I'm an infectious disease specialist who is very interested in HIV, and we basically are sort of mentoring, just like Dr. Sweet had said, by distance, primary care doctors and FQHCs that are willing to step forward and take on HIV care. And it's been going really well. It's a grant-supported mechanism, so sustainability is a very big concern of ours, whether this is going to go, but it's called Project ECHO. And it works to support people that are willing to be primary care docs that take that step forward and say, I will care for HIV people. It's rewarding for me as an HIV specialist to feel like my reach, and all of you that are HIV clinicians, that your reach can go beyond your own clinic. And I just think it's a nice opportunity to address some of these really big challenges that we have ahead of us. So, thanks.
Thank you. That's great. All right. Well, I appreciate the last comment in particular. I mean, all points of view obviously are extremely valuable. I do think we have to come back to the optimistic level of this, that this is, with all of its ups, downs, and very difficult issues that we're going to have to work through, a major advance for not just people with HIV/AIDS, but all people who live with imperfect health or might in the future, which is all of us. I wanted to see if any of our panelists had any closing or any other point they want to make before we conclude the panel. So, anybody? Oh, great. Well, please join me in thanking these terrific panelists. And I know we want to thank the people who have gotten up to ask questions and make points. It's really enriched our conversation. So thank you. Okay. Oh, great. Well, our next speaker, in continuing this conversation, I really see that from our conversation it's really one stream of thinking, so this is terrific agenda. Deborah Parham Hobson, who's a former colleague of mine at HHS and another person who has been really working incredibly hard for many years in addressing the epidemic. She is the Associate Administrator for HIV/AIDS at the Health Resources and Services Administration, which is part of the U.S. Department of Health and Human Services, and it is the part of the government that operates and oversees the Ryan White Care Act. As you know, the Ryan White Care Act funds medical care, treatment, referrals, and support services for uninsured and underserved people living with HIV disease, and also works with healthcare professionals for training. She also holds the rank of Assistant Surgeon General and Rear Admiral in the Commissioned Corps of the United States. She gets a very nifty uniform for that. And has received many honors, but I think the most important honor is the thanks from a very grateful community who has benefited from her work, and we look forward to your remarks. Thank you for coming.
Thank you for that kind introduction, and good afternoon. I know you've been sitting for a minute, so why don't you just take a 15-second bio break and just stand up, breathe, move around. We don't want DVT in here, so. And while you're doing that, I just want to thank the American Academy of HIV Medicine for hosting this very important forum. You can all sit down when you want. Okay. It's like church, you know. Okay, stand up, sit down. And thank you to the Academy also for inviting me to participate. I will say that I was scheduled to be earlier on the panel, but I had a conflict, so thank you to the Academy and to Dr. Cha for switching places with me. The challenge with doing that, though, is that as I heard the conversation, I said, yeah, that was a point I was going to make. Yes, that's a point I was going to make. So it's a bit of a challenge to stand up here and tell you what you already know. But there are some points that I did want to emphasize. And based on some of the questions that I heard in the last session and some of the concerns, I do want to assure you that we in HRSA, working with CMS in particular, are very aware of some of the issues, but it's always great to hear from you who are on the front lines actually out there providing the care. What are those issues that you are seeing and hearing and working with every day as you're trying to provide care to people living with HIV? And as we transition people into the Affordable Care Act, which I agree is a great program. It's going to cover a lot more people with insurance. We understand that insurance doesn't equal access necessarily, but there are lots of good things in the Affordable Care Act, and I'll cover some of those. But one of the things that I keep hearing, and I heard a little bit of it in the previous session, is we talk a lot about outreach, identifying people who are, the whole cascade, identifying people who are HIV positive, linking them to care and retaining them in care. And I'm very concerned that with the little 19% that we've retained in care and gotten virally suppressed, I don't want that number to go even lower, because we now find that people are not transitioning to a new provider. They are dropping out of care. So that's one of the big concerns that I have as we move forward. So working with all of you, we need to figure out how not to make that happen. Now I'll do my prepared remarks that my staff prepared for me. Yes, I do want to talk to you this afternoon about what I was asked to talk to you about, which is what are some of the things that we think that Ryan White providers in particular need to know as we move forward with full implementation of the Affordable Care Act. We know that as recently as November of last year, only 13% of people living with HIV and AIDS in the U.S. had private insurance coverage, and nearly a quarter of people living with HIV and AIDS had no coverage at all. The remaining population of people living with HIV relies on state and federal programs for their HIV care, programs like Medicaid, Medicare, and the Ryan White program. With the recent Supreme Court decision to uphold the Affordable Care Act, at least most of it, we believe that it's imperative for providers, patients, and the HIV/AIDS community to be aware of how these programs and the private insurance market have or will be affected by the Affordable Care Act. I want to review some of the provisions, and if you've already gone over this, please indulge me. But we do know that there are many provisions that will positively affect people living with HIV. No longer will there be lifetime spending caps from insurance companies, and there will be no annual caps beginning in 2014. That's a good thing. Insurance companies, and we've talked about this, I heard it earlier, will no longer be able to deny coverage based on pre-existing conditions such as HIV status for children, and beginning in 2014, the coverage cannot be denied for adults with pre-existing conditions. Insurers cannot rescind coverage for adults or children because of a change in health status. So these are real good things that are part of the Affordable Care Act. In terms of federal state program changes, ADAP, we have heard a lot about the AIDS drug assistance program and the waiting list. The ADAP benefits already count towards the Medicare beneficiaries' true out-of-pocket spending, or TROOP. And that's a huge relief for people living with HIV who are those beneficiaries, because it moves you more quickly through the donut hole. So that's a good thing. That took effect January of 2011, so that's already in place. New insurance coverage options will become available for people living with HIV and Ryan White clients, such as increased access to Medicaid for many states for childless adults up to 133% of poverty, and we certainly heard that discussion in the last panel. The question was asked about the data. We have spent the last few years putting together this wonderful, elaborate, and some of you who are providers who are actually providing the data may disagree, but a wonderful, elaborate client-level data reporting system. And it was put together before the Affordable Care Act with the 133% of poverty. So when you're putting together a data system, sometimes you just don't think 133. You go 0 to 100, 100 to 200, and so forth. So when the Affordable Care Act talked about 133% of poverty, we very quickly knew that even with our new data system, we did not have the data point that we now need. So we need to go back and figure out how we can rejigger, go back through OMB for clearance on our data system so that we can get the information that we need to answer these very big and broad questions. In the meantime, we're doing some estimates. Now back to my points. Some other provisions that will be in the law, Medicare and many private insurance plans are now required to cover recommended preventive services, including HIV screening. And there are a number of things. I think you're very familiar with many of the specifics in the law about how it will affect people with HIV. Well, one of the things that I wanted to talk about is the interaction of the Affordable Care Act with the Ryan White program. We know that the Ryan White program currently wraps around many of the Medicaid services because by statute, it's the payer of last resort. When you think about it, and I'm going to talk about some of the challenges of that a little later, but when you think about that, even with expanded or not expanded Medicaid, and even with Medicaid being different in different states and in California in different counties, the Ryan White program would still wrap around whatever you have. So the administration is very supportive of continuation of the Ryan White program, even though it needs to be reauthorized in 2013. And there's a backstory of why 2013 as well. And just as the Ryan White program looks different in different states, in different communities, it will continue to look different in different states and different communities. But that's not any different than the way it is now. It continues to be the payer of last resort. It continues to wrap around services that are paid for by other providers. So in Texas, that Keith Rawlings talked about, the fact that they have a limited formulary or limited prescriptions that people with HIV can get. Well, the Ryan White program wraps around so that the people living with HIV in Texas do have access to a full range of services that they need. The challenge comes when the Ryan White program, with this flexibility, people are asking, well, will the program still change? And what about the 75%, 25% core service requirement? Well, I will also remind you that there's a waiver. And for those of you who are Part A grantees, those 52 EMAs and transition grant areas, this is a commercial, the application is on the street. And you submit with your application if you want a waiver from that 75%, 25%. So for California, you want more money for case management. Now is the time to think about that and think about how those dollars could be reallocated if under the LIP program, the Low Income Health Program in California, more people, which is the bridge to 2014, more people are already covered for their primary care services. And if you can show that and if you can document that, then there's an opportunity there to ask for a waiver from the 75-25% core services, support services, so that you can spend more money on those support or wraparound services that are so important and perhaps even more important now as we transition patients from one provider perhaps to another provider so that we can keep them in care. It's oftentimes those support services that are necessary for that to happen. One of the other things that we're concerned about is reauthorization. I mentioned that earlier, that the Ryan White program is authorized now through September of 2013. And when we were doing the reauthorization in 2009, people looked forward and said, ooh, 2012, that's going to be the election. We don't want the Ryan White program to get caught up in re-election politics. So let's reauthorize for 4 years. And that's what happened. It was reauthorized through September 30th of 2013. Well, that was September of 2009. Who knew that in March of 2010, we would have the Affordable Care Act with a very critical date of January 2014. So we have a little gap, and we're trying to figure out the bridge of Ryan White from before ACA to after full implementation of ACA. And there are some unknowns, but there are some things that we do know. One of the things that's proven successful is payer of last resort, to help people who are low income, uninsured, or underinsured gain access to high quality and effective HIV care. Well, that presents a problem when you have people who are transitioning, and I'm still learning the ACA myself, but as you're transitioning, there will be a window, kind of like when you have the federal insurance benefits program and you have a re-enrollment period from October to December. Well, what happens if you come and see the Good Doctor Suite in September, and then you're not scheduled for another visit for 6 months, and you don't realize that you have to enroll in something else October through December, and you miss that enrollment period, even though you're eligible for expanded Medicaid services, if perhaps, I'm just using you as an example. After you've told me that they may not expand it in Kansas, my example kind of falls apart, but just go with me here. If that person living with HIV is eligible for expanded Medicaid, Ryan White is the payer of last resort, and the person just chooses to stay with Dr. Donna because they really like her services and don't transition, that's a challenge. What flexibility do we have in the Ryan White program to make sure that we don't do harm by saying, well, you should have enrolled in October through December, you didn't. Ryan White's payer of last resort, so she can no longer be your physician. So we have to work to see what flexibilities we have with payer of last resort, because we know from many examples, California, Massachusetts, that it's not a smooth transition. It's a process. We will be transitioning for, I think, years before everything is settled out. And from what I understand, 2014 is a very critical date with the Affordable Care Act, but there are many dates in the teens all the way out to 2020 with various provisions being implemented in different ways in different years. So as we go through this journey of fuller implementation on January 1, 2014, but continuing with implementation for years to come, what is the role of the Ryan White program? How does it wrap around? What flexibilities do we have? One of the challenges that I have now is that I'm looking to see what flexibilities do we have with current law. For example, we know about the 75 or 25% waiver. We know about payer of last resort, trying to figure out if there's some flexibility there. Because if someone is not eligible to transition, we do know there's payer of last resort, then the Ryan White program can pay. And as people are transitioning into the Affordable Care Act or expanded Medicaid, sometimes it takes a while for their eligibility to catch up. And so can the Ryan White program pay for their medications while they're getting fully certified under Medicaid, because that would be payer of last resort. So we're working with our attorneys now to see what flexibilities we have, because it's not a matter of just trying to adhere to the letter of the law, which we do, but it's always keeping our eye on what is it that we're trying to accomplish. After we've gotten these people into care, gotten them on medications, gotten their viral load suppressed, we want to maintain the high quality of care that they're getting. And so we use the law to help us do that, not to prevent that from happening. I'm going to skip some of this. If you are a Ryan White provider, some of the suggestions that I have, and from the questions that I've heard, you're already doing some of this, is to begin planning to screen clients who may be newly eligible for Medicaid or other coverage available in your state or your county. Also, learn which wraparound services may be needed most in your state based on coverage offered in health exchange plans and Medicaid. One of the other suggestions that I heard, and I'm going to appropriate it for my talk, is don't ask to be invited. Go to find out from your state or in your state when those meetings are, how you get involved in the conversation about the essential health benefits. That's a critical thing that is being discussed now. As you know, there's just broad guidelines from the federal government, but at the state level is when people are choosing those benchmark plans. You need to make sure that the plans that are chosen are adequate for the people and the patients and the clients that you serve. Learn I already talked about the essential health benefits. Ensure that your provider team is informed about the Affordable Care Act changes that may affect your patients. Healthcare.gov is another website that is a website sponsored by ASPA in the Office of Healthcare Reform in the Department of Health and Human Services. It has a lot of information on it. Again, it's healthcare.gov, and it's information for providers as well as patients. So we encourage you to not only be familiar with the law, but continue to follow those discussions. There's lots of ways you can get information, the FAP conversations that Donna mentioned earlier. But one of the things, and I want to end with this, is that realize that you are not alone. There are many things that we in HRSA and the HIV/AIDS Bureau are doing. We, too, are working to understand the impact of the Affordable Care Act on HRSA-funded programs and the people that those programs serve. So certainly the Ryan White program, but also the Community Health Centers program, which received significant expansion under the Affordable Care Act, the maternal and child health programs, the health professions program, education programs, rural health. There are many provisions in the Affordable Care Act that affect all of those safety net programs that we manage in HRSA. We are committed to making information available to you. So I was listening to hear what are some of those questions that you still have. And I appreciate Jeff saying that, we're not going to serve everything up to you on a silver platter, but if there are some big, broad things that you need from HRSA or some different policies or questions that you have, information that you need, then I invite you to certainly be in contact with us on what information we need to get out to make it easier for you to do the work that you do. Specific to HAB, I will say that we learned a lot of lessons from our experience with the California LIP program, the Low Income Health Program. We learned about transitioning patients and the challenge of making sure that we don't lose patients to care. We learned that changes may not be statewide, but vary by county or jurisdiction. We learned that it's really important that the networks have the appropriate providers so that we don't have male patients being referred to the gynecologist for their HIV care. We learned about payer of last resort, and we need to have some flexibility there. Based on these lessons, we are taking a hard look at what flexibilities we have under the current law, and we are committed to issuing policy about that. We also realize that some changes are necessary to the Ryan White statute, which is up for reauthorization in 2013. So the timing may not be the best, but we are looking at reauthorization to actually build more flexibility into the Ryan White program. We're gathering input from you and other stakeholders about changes in the Ryan White law. I just concluded 4 listening sessions, and I know that some of you were on those calls, and I heard a lot from people living with HIV, from Ryan White providers, other stakeholders, giving us some information about the challenges in their states with the Affordable Care Act. And I will say that I was listening for what are some of the ideas people have about changes for the Ryan White law. And I will say that most of what I heard was questions about what will the Ryan White program look like after the Affordable Care Act is fully implemented? Will social services still be provided? Housing and transportation, those support services are so critical. Will they continue? What about services that are not covered under Medicaid, like oral health? So there were a number of questions that people had that certainly gave me pause and helps inform me of what other information people do need. I do know that there are still some unknowns, and I understand you heard some of those from Dr. Cha. So we're still working very closely with CMS. Our relationship with CMS has never been so close. So this is a good thing. They're learning our language. We are learning theirs. So. And I know some of you might be saying, I'm a clinician. I just want to take care of my patients. That's why I got into this field. We are committed to working with you as you continue to do what you do best, which is to move heaven and earth to provide a full range of services for your patients. Yes, the healthcare landscape has changed, and it continues to change. But I would argue that HIV also changed the healthcare landscape, but you rose to the challenge and you helped build a system of care for people living with HIV and AIDS that is unrivaled in the world, and for that you should be congratulated. So I know that you're up for this challenge as well. This week, many of your successes will be showcased. So I thank you for what you continue to do, and I look forward to continuing our partnership as we turn the tide together. Thank you very much. Do I stay here or stay here? Okay.
Thank you very much. Questions? A couple of questions from the audience? Yes.
Dr. Hobson, I'm from South Carolina, one of the states whose governor doesn't want to expand Medicaid. So and I work in an HIV-only clinic. And a couple of questions I have for you. How secure is the 340B funding for Ryan White clinics? I guess one of our concerns in our clinic is we're not an FQHC, but the 340B funding is how we pay our bills and to supplement our Ryan White funding.
Yeah, right now the 340B program is secure. I mean, there's certainly always a lot of questions about it, and there are certain sectors that don't really like this 340B program, but right now it is secure, and we do encourage our Ryan White providers to take full advantage of that.
And do you think that will still be the case once the ACA is fully implemented?
I don't know.
You don't know. Okay. Do you, and you may have the I don't know answer to this too. Do you think the Ryan White only, the HIV only clinics are sustainable?
That's a great question. And I would ask some of the others who are here in the audience to help with that question. What's your crystal ball telling you?
That was one of the problems that I brought out before you arrived here.
Oh.
That I quit a Ryan White clinic because we weren't able to, and I went back to private practice trying to transition my clients into a more of a managed care and private setting because we weren't able to provide the primary care services because of the restrictions of the Ryan White clinics and the cut in monies. They ended up denying a lot of laboratory services, primary care labs, and telling them to find primary care providers, where originally the whole concept of the Ryan White Clinic was one-stop shopping, comprehensive care type services. And we reversed that by starting to refragment all these issues and farming out primary care to primary care providers for heart services, cardiac medications, non-HIV related medications, but what we're finding now that all these medications are related to chronic primary care HIV. And so therein lies our conundrum or crux of the problem. How can we still make these Ryan White services, wraparound services, still relevant in helping what you just described? And how can we keep that group communicating with primary care services and get these people the comprehensive care that they're going to need because of the aging and the chronicity now that we are dealing with HIV?
Yeah. What I would say is that when you look at the Affordable Care Act, what systems of care were expanded? It wasn't the Ryan White program. It was the community health center, the primary care clinics. So if I had to do prognostication about what I think would happen, that's what I'm seeing happening is expansion of those clinics. So what I have tried to do is to encourage, and I don't want to carry this analogy too far, but to encourage Ryan White only providers to marry a community health center in some kind of way, so that community health centers who serve all comers, regardless of ability to pay, can provide some of those primary care services, and the Ryan White dollars can pay for those HIV-specific services. I know that that's not a panacea, and I know that that doesn't work in all communities. But when I look at where the expansion, as I said, where the expansion has happened, at least in the safety net programs, it has been in those community health centers. So I heard the gentleman from Seattle talk about the telehealth program. What we said in HRSA and in the HIV/AIDS Bureau, that if that's the place where the expansion is happening and more people living with HIV will go to health centers, how do we bring them on board and bring them up to speed in terms of being able to provide high-quality, competent HIV care? And the telehealth program is one of the ways of spreading the expertise that we have garnered in the Ryan White program beyond the borders of the Ryan White program. Certainly the AIDS education and training centers as well can also provide training for people who are working in community health centers, not in Ryan White specific centers.
But that in and of itself, in its own way, is fragmenting the care once again, because the Ryan White centers are being forced to send these people to these community health clinics because they don't have enough funds to help with those wraparound services. So how can you communicate to these clinics that they are still partly responsible or can help in some way when the qualified health care clinics or the new managed care plans fall short they can actually be flexible with the payer of last resort and still help provide some of these primary care issues.
Yeah, I hear you. It's not a answer that I can just give you the panacea and give you the answer today. It's certainly those questions and challenges that we continue to face, and I will continue to work with you to make sure that we are able to provide the full range of services for people living with HIV wherever they end up getting their care. Next question.
Sir?
Yes. My name is Joey Wen. I'm from Fort Lauderdale, Florida. First, let me say it's refreshing to see so many people from the South being able to be here and convey our stories and our challenges in providing HIV care in the South. I have two difficult issues, and my question is how you're intending to move forward in terms of finding solutions. The first one is about funding formula for states in the South that know that they're not going to expand Medicaid. I think you've heard from a variety of us from different states, and being from Florida, we have an excellent relationship with our Medicaid office. We have elected officials that aren't going anywhere. They're elected until their term limits. They're very safe in what they say and what they do because of who votes for them and how things turn out. So we feel there's an opportunity with reauthorization to ensure that we don't get penalized for those states that don't do Medicaid expansion because either limited state budgets, there are no state income taxes, there are no mechanisms for us to have money. It's not that there's lots of money and they're determined not to give it to us. It's simply there is no money. And so how do you not penalize those states that don't have Medicaid expansion, that don't have all kinds of other payer sources to enrich their programs, because there's a huge disparity for us in the South. We don't have basic access to medication and medical care for many people, and yet we see other states that have great state support and Cadillac model healthcare systems for people living with HIV. We look at this reauthorization during Affordable Care Act and Medicaid expansion as a potential to harm us even further and have a greater disparity. I know that's a difficult issue, but we're looking to how will you look for information and solutions from the South in particular in this kind of larger construct that's going to penalize people living with HIV in the South. And no, we don't want to move to other states. That's not an option.
No, I wasn't going to say that. Realizing that there are real differences, geographic differences. The very first listening session we had focused on regions 4 and 6, which are those states in the South. There is still opportunity to provide written comments, so I urge you to go to our website and provide your comments that way. That way we have a list of all of the issues that have been raised from people around the country about and ideas that people have as we move towards a different solution in a reauthorized Ryan White program. So I heard you talk about funding formulas. Those are statutorily driven. So in order to change those, we would have to change statute. So it would help if we had some written comment from people who are living in these various jurisdictions to say, this is what we're seeing in our jurisdiction, this is what we're seeing in our state, in our community, and because of the various circumstances, we need some different formulas in the Ryan White program. But I will say all of the formulas are statutorily driven, so it does take an act of Congress to change those.
And secondly, what are the options to have demonstration models like CMS with their Centers for Medicaid, Medicare Innovation, to have something very different exist within the CARE Act itself?
Yeah, we only have the SPINS program for demonstration programs within the Ryan White law. Again, our law, as you know, is very prescriptive. You must do this with Part A, this with Part B, and there's not a lot of flexibility there. So again, the SPINS program, the Special Projects of National Significance, is the only program and the only dollars dedicated for those kind of innovative ways of looking at care and then evaluating those models that work and then integrating those into the other Ryan White programs.
Thank you.
You're welcome.
I'm David Schmidt again, formerly of Miami, and I'm moving a little further south in Fort Lauderdale. Ever since the early 90s, practices with large numbers of HIV patients, primary care, have never been able to be adequately funded. And there's been a sort of tacit but integral private-public partnership between the pharmaceutical industries that use our groups of patients as a basis for dubiously scientific but clearly commercially valuable studies. And it is the revenues from those studies which have kept a number of the South Florida practices afloat. We're talking practices with 2,000 to 3,000 HIV positive patients doing primary care. Without those, right now, those practices would go under. New alliances have been made with other private entities. But in no time in my 20-odd years of experience in that area have a practice devoted to primary care HIV in which we posit ourselves as the direct caregivers to the patients and the consultants work for us so that we can avoid the problems of multiple opinions and unnecessary conflicting medication by being the last person who gives, the only person who gives advice. Without the participation of somewhat self-serving but as I say, valuable pharmaceutical participation, none of those practices could have survived. And I think that trying to understand primary care, HIV primary care in the absence of that off-the-books sort of contribution is dangerous because that really has kept several thousand HIV patients in primary care in that area.
Hi, I'm Carol Treston with AIDS Alliance and the AIDS Institute. I'm actually going to repeat a question from earlier. I don't think you were here for it. And that's about pathways for Ryan White providers to become medical homes, and including technical assistance that's required, and are there any kind of, this was your question, so if there, and of course the medical home means enhanced Medicaid and Medicare reimbursement. So if you can talk a little bit about pathways to that for Ryan White providers and technical assistance that may be
very little
provided.
bit about it. We do have a technical assistance contract. Harold or Michelle, do you remember who that's with? I can't remember. But we do have technical assistance with a, it's a cooperative agreement. I just can't remember who it's with, but I can certainly get that information to you. About Ryan White programs that want to transition to become medical homes because we do know about the enhanced rates, and so we're trying to figure out what are those opportunities that are available under the Affordable Care Act that would benefit the Ryan White program. So we do have technical assistance available. We're very aware of it. I just can't remember who it's with right now.
Well, let me thank Dr. Hobson and also just thank her for all that she does for us. We're going to have one more speaker, and I just want to make sure if he's here yet, but let me thank Deborah, and please join me. Our next speaker is joining us from the Office of National AIDS Policy at the White House. Dr. Aaron Lapata is on detail to that office from the Office of Management and Budget. And for those of you who are familiar with Washington, OMB sort of controls all the books. So it's wonderful to have those two offices working so closely together. He's also a pediatrician, so he understands from a provider point of view all of these issues, and he's worked on national AIDS policy issues for quite some time. He's working with HRSA and with other federal agencies to make sure that grantees are prepared for this transitional year of 2014. So I think based on the conversations we've been having today, his comments and his availability for questions will be a perfect way to connect these dots. Prior to working at OMB, he's also worked as a health policy fellow for both Congressman Henry Waxman and Congresswoman Jan Schakowsky, two leaders in the House on healthcare issues. So welcome.
First, thank you so much for inviting me to speak to the Academy. I really appreciate the opportunity. And then I realized when Dr. Parham Hobson had mentioned that what else is there to say after Dr. Cha, our esteemed panel, I'm in even a worse position because now I have to follow Dr. Parham Hobson as well. But I thought that what would be perhaps helpful would be to discuss and talk about these issues from the perspective of the Office of National AIDS Policy and as an extension, the Office of Management and Budget, since I am full-time at the Office of Management and Budget, and right now for the late spring, well, from late spring to early fall, I'm at the Office of National AIDS Policy, so I am somewhat wearing two hats here. What do we see as our role in addressing these issues from this perspective, which is sometimes 10,000 feet height, and we're obviously not on the ground, but we are trying to learn as best we can what's going on the ground and what the challenges are. And so I want to discuss a little bit what we're looking at and what we're really trying to do. I think one of the reasons I was invited to come over to ONAP from OMB, I should state that I've been at OMB for 8 years. I've been working on the Ryan White program and had the pleasure to work with Dr. Parham Hobson and her team for 8 years now. And so I think one of the reasons I was asked to come to the Office of National AIDS Policy was to in part work on these issues, one of which is, well, the overall issue of ACA transition. One, first trying to get a better sense of how ACA transition, or beginning in 2014, is going to impact the Ryan White program and get an idea of the impact on the Ryan White budget and the impact on Ryan White program programmatically, so we have some idea of what to expect when we start looking at the 2014 budget this fall. And of course, the other issue is how do we work with and understand better the challenges faced by Ryan White grantees, but all federal grantees that work with the HIV/AIDS population, whether they're health departments, whether community-based organizations, and of course, whether they are providers. And what are the challenges they're facing going into 2014, or what are some of the things that they're going to have to do and be prepared for starting in 2014 when all these changes happen and the expansions of health insurance, and what kind of assistance do they need? And I think one of the things I think is obviously key is providing technical assistance, of course, and in order to do that, we need to understand very clearly what the challenges are. And everybody has talked about it today a great deal, what the challenges are, and there are many. And I think I'd like to also note that, as others have stated here, there's also great opportunities, but there are, of course, great challenges. And I think one of the things we're trying to do, and I'm trying to do this summer, is learn from providers, and that's also helped listening to some of the discussions here, but also having calls, meetings with providers and learning what are their needs, what are the problems, what are the challenges, and what kind of technical assistance do they need, and in order to prepare and be ready for 2014. And not just providers, but also state health departments and community-based organizations. And I think this is really important because, well, let me state that one of the other things that we're constantly doing at the Office of National AIDS Policy is also trying to implement the National HIV/AIDS Strategy. And then you have those challenges as well. And that also requires a new way of thinking about things. And the strategy's done a great job of focusing on, what do we have to do? How do we refocus our funding to the areas of greatest burden? How do we coordinate federal resources better? Not only at the federal level, but on the ground. How do we work with communities to implement coordinated systems or more coordinated systems to implement effective cascades, outreach, to testing, to linkage to care, retention and care, which I think has even gotten a higher profile now with the treatment as prevention, the recent research showing the effectiveness of antiretrovirals when, obviously people are virally maximally suppressed, of preventing transmission of the virus. I think there's even more of a focus now on helping communities implement these types of effective cascades, and it doesn't just require one provider or one clinic or one health department. It will take and is taking communities working together and health departments, community-based organizations, and providers all working together as a team. But of course, you have that challenge, and then you have the ACA, which is a tremendous opportunity, but there's all those challenges that come with it. And so we really want to be able to help providers and all federal, whether you're a federal grantee or not, be able to deal with this transition in a way that when 2014 comes, you're not so overburdened that we're not able to do these other things that will, again, be required for communities to implement this effective cascade. And I think one of the things I've learned, well, I've known for a while, and I think is the other component of what we're trying to do, is when addressing, so you have all these issues we've talked about today in terms of challenge of ACA, but one of the things that is not new to people who are any federal grantee for any agency is the current reporting burden that grantees are facing, again, from all agencies. And how that is making, I think, implementation of national strategy more difficult when, again, you have these challenges and we're asking communities to do more and coordinate more. And then on top of that, then you have all this work that has to be done in terms of the ACA transition. So we're going to be asking people to do even more while there's also all this reporting burden that is, again, I think remained a very significant problem. And it's a problem that is not the fault of any one agency or all agencies. OMB deserves responsibility as well. And I think that this is something that we're going to be focusing on a lot over the next few months and over the next year. You know that the Secretary of HHS had released a memorandum calling for not only development of core indicators, which the Assistant Secretary at HHS, that office is getting ready to release, but also to reduce the reporting burden by 20-25%, which we would like to think is at least 20-25%. And I think, though, as part of that process, that we at ONAP and at OMB could work with the department to sort of address the area from the top down as well, and figure out what can we do to help the agencies find flexibility. Again, that's not in statute. As Dr. Parham-Hobson said, the statute is certainly a limitation, but I think there's places we can make a lot of gains outside of the statutory requirements, where we can make some changes that I think will really help free up the federal grantees, whether you're a provider or whether you're a health department, so they can focus more of their resources on actually providing services rather than spending so much time pulling data manually, from one system to another, or doing a report every month on something. And so that's the other thing we're going to be focusing on, because again, I think it's going to be an issue that has to be addressed if providers are going to be able to deal with the ACA changes that are coming in 2014, and I think also if we want to see effective implementation of the strategy continue. And I'll also say that, one of the other issues we will also want to focus on is this, and this has also been discussed, is the challenge in terms of the burden on providers. And in terms of, and again, I think we saw this, or we have seen this in Massachusetts to some degree as well, that the providers have been strained after they passed health reform, and this is not something new. This has been a concern not just among the HIV/AIDS population, but among the across the country generally after the Affordable Care Act was passed. Are there enough primary care providers? And then the second question, of course, we were dealing with today, are there enough HIV/AIDS providers? And so I think these are unique challenges that we also want to continue to work with the agencies, work with HRSA to address. And I think there are different ways to address this, whether it's through the AETCs, whether it is through the Bureau of Primary Health Care, and I think it's also working with the HRSA's Rural Health Policy shop, as well, as they have unique ways of providing expertise to specialists in rural areas, but I think we can use such as telehealth, telemedicine, that we can also use for primary care providers, whether they're in health centers or not in health centers, to provide the specialized HIV care. And so I guess I want to end by saying we, and I say we at ONAP, and I will continue to do this when I go back to OMB, are constantly in a state of listening and learning from providers on the ground. Not only providers, but also, again, say health departments and community-based organizations, is what are the challenges that everyone is facing, and when and where we can, how can we address them? And of course, this also involves working with the agencies, listening to the agencies, for them to tell us what are some of the limitations they're facing, what are the challenges that they also have that we can, at OMB or ONAP, can respond to as well, to help them provide the assistance, technical assistance, or any other type of assistance to their grantees. So going into 2014, we are in a better we're in a better position to handle the ACA transition, and in a good position to continue making progress through the implementation of the National HIV/AIDS strategy that we've made such good progress so far. I hope that, well, I know that that will continue, but I think addressing a lot of these issues, including a lot of the issues that we talked about today, is going to be a key part of that. So.
I think we have time for maybe one or two questions, and particularly from anyone who hasn't had a chance to ask a question up to now. Seeing no takers, let me thank Aaron for joining us and appreciate his work. I think this was an extremely informative afternoon. Some of the best minds working on these issues, and in particular the best minds working on the ground taking care of patients. I think we've identified a lot of issues, and a lot of folks are going to be following up on that. I hope there'll be lots more conversations that will continue as we move forward. Want to see if Jim has any closing remarks. So thank you very much for your attention, and I'll turn things over to Jim.
Well, this has been quite a day. I want to thank all of the presenters. I think you guys were terrific. I want to thank Richard Sorian. You did a terrific job of bringing all of this together. Let's give all of them a big hand. I also want to thank all of you guys in the audience, not only for joining us here today, but for the work you do in your offices and your practices across the country, which is really what we're all here for. And I want to give you guys a hand too. Finally, I want to thank Holly Kilness. Stand up, Holly, in the back. Holly's our Director of Policy at the Academy, and she did all of the hard work on this, and we very much appreciate it. And I have a list of things that my staff has told me to tell you before you leave, okay? There are packages at the back of the room, okay? Take one if you haven't already. In those packages, Holly's holding them one up. In those packages is an order form for fundamentals, the new fundamentals. The one and only copy that exists in this nation today is now going to be available this coming week. So those of you that have ordered them already, they'll be in the mail towards the end of this week. Those of you that want to order one, this is the 2012 edition, you know. And David Hardy, is David still here? Is the editor-in-chief, and Bruce Packett, who is also on our staff, who managed this process, enormous process, and it's now here. There's an advocacy piece. We're talking about state advocacy. There's an advocacy piece in those folders, so take a look at that. And finally, the next issue of the HIV Specialist, which is our magazine, our quarterly magazine, will focus on many of these same issues that we've been talking about today. So that should be out towards the end of September, early October, Amber, somewhere in that range. So there'll be more details on that as well. But again, thank you all very much, and I hope we see a lot of progress in the week ahead here at the conference. Thanks again. Bye.